Well, good afternoon, morning, or evening, as the case may be, wherever you are. I'm Michael McGinnis, the Executive Officer of the National Academy of Medicine, and it's my great pleasure and privilege to welcome all of you to this meeting on financing that rewards better health, equity, and well-being, and with a particular focus on state innovations that are leading the way. This is a meeting that's part of a series of activities under the auspices of the National Academy of Medicine, working in close collaboration with a number of partners, both within the academies and throughout the nation. And we'll mention a little bit more about that later on. This is an especially important meeting from our perspective because of the key role that states play in our efforts to move the health system to greater effectiveness, efficiency, and equity. And in our efforts to do that through changes in the way we think about payment for healthcare and health. I'm going to give you just a little bit of background on the National Academy of Medicine's Leadership Consortium for a Value and Science-Driven Health System, which is the parent body, if you will, for the initiative that is currently underway. And it focuses specifically and predominantly on effecting collaboration that can be important to advancing progress. So I'll show you a few slides in that respect. If we can have the next slide, please. Let me just note here that Mai Pham, who is my co-convener of the meeting here and the chair of the steering committee for the planning effort, will be speaking to you shortly, and I'll give you a little more background on her, but I want to especially acknowledge her with great gratitude as we move to the next slide. We're also going to have today with us Jonathan Blum, who is the Deputy Administrator of the Centers for Medicaid and Medicaid Services. And I'll tell you more about John in a few minutes as well. And our two panel moderators are Cheryl Powell and Josh Sharfstein, who are both members of the steering committee and have been extremely helpful all along the way in advancing and informing the nature of the conversation. Next slide, please. The Leadership Consortium that I mentioned is comprised of stakeholder leaders from private, public, and independent organizations, including, for example, the heads of the major federal agencies involved. And all of these organizations are united in their common interest for advancing effectiveness, efficiency, equity, and continuous learning in health, medical care, and biomedical science. And despite the extraordinary resources that we devote to health and healthcare in this country, we are falling short of the mark on each of those dimensions. So the conversation today is extremely important in helping us to close that gap between where we are now in effectiveness, efficiency, equity, and where we can be if we better deploy those resources. Next slide, please. As I mentioned, the consortium works through a series of collaboratives, one focused on science, the Evidence Mobilization Action Collaborative, which is aimed at enhancing the use of real-world evidence. One focused on informatics, the Digital Health Action Collaborative, which is focused on nurturing the digital infrastructure and data that are derived in the course of health and healthcare as a core utility for improvement. Incentives, very much the focus of today's meeting, Value Incentives and Systems Action Collaborative, payment based on health outcomes for people and populations. That is the aim that we have in today's meeting. And Culture, Inclusion, and Equity Action Collaborative, that is full and equitable health engagement for people and communities. These are in the spirit of the enterprise as a whole, These are not separate, but equal. They are certainly all equal and important, but they are intersecting, very much intersecting. And at the heart of the intersection is the way we structure our payment and incentives activities, hence the importance of today's meeting. Next slide, please. What you see here is an example that has been particularly prominent over the past 18 months of the collaborative work to identify and engage emerging and present problems. And this is the indication of the 9 different sectors and the key organizations involved in each of those 9 sectors, which were required to respond to the COVID-19 pandemic. And we've spent the last year or so with a deep dive into the experience of those 9 sectors and the findings that their leaders have identified about cross-cutting transformations that need to occur if we're going to emerge stronger as a health and healthcare system. And indeed, that's the overall umbrella focus of the sector assessment initiative, that is emerging stronger. And as the efforts turn to the cross-cutting themes, none is more prominent than health financing and the way we pay for health and healthcare with the incentives and signals that it contains. Next slide, please. I want to point out here, again, with some specificity, the fact that we've had a steering committee helping to guide us through this set of activities on financing that rewards better health, equity, and well-being. It's, as I mentioned, led by my femme, who's the president and CEO of the Institute for Exceptional Care. Again, I'll mention a little more about her in just a second. Also involved are Margaret Chesney from UCSF, Dina Chisholm from Nationwide Children's Hospital, David Erickson from the Federal Reserve Bank of New York, Chris Kohler, president of Milbank Memorial Fund, Peter Long, senior vice president of Blue Shield of California, Cheryl Powell, senior principal at MITRE, Josh Sharfstein, vice dean at Johns Hopkins School of Public Health, Dexter Sherney, chief medical officer at Adventist Health, and Sarah Zanton, dean of nursing at Johns Hopkins. An extraordinary group of extremely dedicated and knowledgeable folks who are actively helping us in this work. Next slide, please. And a special mention is indicated for our philanthropic partners and sponsors. The Sam Yelley Foundation, the George Family Foundation, Nemours Foundation, the WellBeing Trust, the Whole Health Institute, and I'd like to give a particular shout out to Wayne Jonas, who has been of the Sam Yelley Foundation, who has been especially helpful in coordinating the work of these foundations together. And the important issue here is that their commitment and engagement spans far beyond just the sponsorship of individual meetings, but they are committed as individual organizations and as a collective, if you will, to doing everything that can be done to marshal society's will to move financing toward whole person and whole population health. And those are fundamentally important concepts that underlie the meeting today. And again, thanks to our foundation colleagues for their leadership in that respect. Next slide, please. I'm going to pause here at the moment and introduce my close colleague and partner in this activity, my fam. As I mentioned earlier, my has been with us as chair of the steering committee at every step of the way. And it's very unusual that one finds an individual who has the blend of brilliance, caring, and strategic instincts, marshaling on behalf of people struggling with a long and difficult road in life. But Mai is clearly one of those individuals. She is an internist by training with a master's in public health from Johns Hopkins, where she was also a Robert Wood Johnson Foundation clinical scholar. She has been engaged both in the care for vulnerable patients and the mobilizing of policy initiatives to better engage vulnerable patients throughout her entire career, and served during the Obama administration as the Chief Innovation Officer at the CMS Innovation Center, and following that as Vice President at Anthem. And now she is, in addition to her work continuing leadership in health policy and health financing, is the President and CEO of the Institute for Exceptional Care, which is a nonprofit organization she founded, which is focused on transforming healthcare for people with intellectual and developmental disabilities. So let me turn it over to you with special appreciation for our partnership and your leadership.
Thank you so much, Michael, for the warm introduction and for your leadership on both the Leadership Consortium and on this particular initiative. So it's been a real honor for me to work with the NAM Leadership Consortium on leading this initiative. Financing that rewards better health and well-being is work that emerged in the context of COVID, where inequities across the healthcare system were exacerbated, as we all know, with a corresponding decline in life expectancy. And the fragility that we had already been familiar with of the fee-for-service system just really came to the fore and demonstrated that this is a critical area for change in order to get to these better outcomes. And we can leverage that change, especially if we're oriented specifically towards benefiting equitable whole person and whole population health and well-being. So the initiative is centered on identifying and understanding creative, actionable, sustainable, scalable financial mechanisms and incentives that health system leaders in all different sectors can leverage to accelerate this transformation. For our purposes, when we say whole person, whole population health, we mean optimizing a person's and a population's ability to thrive and live up to their full potential in an equitable manner. The initiative has spanned most of this last year and has consisted of several elements. There was a 3-day workshop series in the spring where we engaged stakeholder leaders on the vision, the levers, and what strategic actions they thought were possible to advance this future of whole person and whole population health. We are preparing a proceedings document from the National Academies that will detail findings from the workshop and allow users to scroll up and down and find the discussions on particular issues. But we're also preparing a special publication surrounding actionable levers for different types of system leaders to deploy to accelerate this transformation. For example, state leaders or health system, care delivery system leaders. Next slide. The idea for this workshop emerged as the intersection between the work that was occurring under the broader initiative and this pandemic moment. The emergence of all of the regulatory flexibilities and funding opportunities coming out of COVID era policymaking really seemed to provide a promising pathway for state and local leaders to take action on the strategies identified through this initiative to accelerate progress and change. As such, we are hoping that this webinar will highlight key areas that the steering committee has identified as creative, high value, sustainable, and potentially scalable strategies for health system transformation toward equity and whole person population health. And in discussing these goals, our aim is to really break the mold and inspire you to take evidence-based action toward accelerating change. In particular, during the workshop in the spring, we discussed the need to invest in human capital as well as infrastructure to improve whole person population health. And so the discussion today will focus on how states might go about doing this. So let's go to the agenda slide. To begin our progress toward this goal, we're so fortunate to have the opportunity to hear perspectives from CMS Principal Deputy Administrator Jonathan Blum on this pandemic moment and the potential that he sees for states and localities to leverage mechanisms available to them to sustainably finance and operationalize equity and population health. Then at 12:45, we'll be joined by Josh Sharfstein and a panel including Denise Smith, Bonnie Silva, Alex Briscoe, and Doug Eby to discuss evidence-based strategies for empowering the health workforce. And at 2 o'clock, we'll be joined by Cheryl Powell, who will moderate a panel with Cody Kinsley, Shavana Howard, and Camille Dobson to discuss the use of one-time pandemic relief funding and regulatory flexibilities in order to invest in these strategies that support whole person health. Then we'll wrap up with a brief reaction and synthesis from all of us, the moderators and speakers, and aim to adjourn the day at approximately 3:30. Before we get started, I just want to touch briefly on some logistics. We are very interested and desirous of having the audience participate with your comments and your questions and your suggestions. So if you have any such feedback or would like to join the conversation, please go to the Q&A box located in the controls at the bottom of your Zoom screen and type in your question or comment there. Please include your name and organization if applicable, and if there's a specific person that you're directing the question or comment to. Speakers, we ask that you turn your video on when you're speaking, and please remember to mute yourself when you're not talking. And then to remind us all, there will be a recording as well as copies of all the presentations that you'll see today made available on the NAM website after the event. So with that, let me send it back to Michael and invite him to start us off with your conversation with John Blum.
Thank you very much, once again. And it's now my pleasure to welcome the Deputy Administrator of the Centers for Medicare and Medicaid Services, Jonathan Blum, to join us here. As mentioned earlier, John is a real veteran and longtime leader for policy advances in health financing at the national level, but also works in partnership with individuals at the local level, and of course is intersecting continuously with those at the state level as well. This is his second stint as Deputy Administrator. It's his first stint, I believe, as Principal Deputy Administrator, but he's had senior leadership roles in health financing for a very long period of time. During the Obama administration, he served as Deputy Administrator and Director of the Center of Medicare, and led the agency's Medicare payment and delivery reform strategies in that capacity. And he's also served as a Vice President for Medical Affairs at Care First Blue Cross and Blue Shield, also on the professional staff at the Senate Finance Committee, responsible for the legislation that governs and enables health financing at the federal level. And in addition, has served at the Office of Management and Budget as a financial expert in the executive branch. So whether it's the executive branch, the legislative branch, he hasn't made it to the judicial branch yet, but he does have a master's in public policy from the Kennedy School, which as a fellow graduate, I'm especially appreciative of. So who knows what will be in the future. John, thank you for your leadership, and thank you very much for being with us today. I'm going to lead off with a question that I think will, in effect, look at the waterfront of the kinds of issues that you're overseeing as you administer a $1 trillion budget and annual benefits and more than $6 billion in operating funds. And I gather that the direct beneficiaries number well over 100 million. But the fact is, those are just, those are big numbers. They're bigger than the budgets of and the service catchment areas of most nations in many ways. But your reach with the signaling and capacity of CMS is even far beyond that. When you think of the capacity of CMS to partner with states in the effort to move our financing system to a more efficient, effective, and equitable series of outcomes, the power is extremely impressive. This meeting, as you know, and as you've heard, is part of a multifaceted initiative on financing that rewards better health and well-being for the whole person and for the whole population. This means, of course, that states have to be key leaders and partners in the effort. They find themselves now, in many ways, in a unique position in that there is clear recognition of the role of states as important leaders in the work. And now with the pandemic relief fund support at this point in time, also resourced in ways that they haven't been previously for moving forward. In undertaking CMS's role, not just as a source of funding and payments, but in the signals that you send, could you describe a little bit about what you feel is the most important signal you'd like to send to the states as we move from a payment system which is dominantly fee for service to one that is focused on paying for outcomes, and also the ways in which you think the partnership between CMS and the state initiatives can be most productively played out.
Great, thank you, Michael, and thank you, Mai. It's great to see you on the call today. And I think just maybe to start to answer the question, there's a couple of things that we think about here at CMS that I think may help to really frame the overall conversation here. The first is there's nothing that CMS does, and I'm sure from a state perspective too as well, that the kind of COVID kind of response doesn't shape. And I think when Mai and Josh and others here were starting the kind of CMS journey, say maybe 10, 12 years ago regarding value-based payment, kind of shifting towards value, the notion really was then that cost savings was really the primary goal. And I think where CMS today is really shifting its thinking towards how we think about payment models for the future, not just to achieve savings or to achieve the kind of three-part aim, but to help support what we think is a more resilient healthcare system, a better prepared healthcare system. From some data points we see, particularly on the Medicare side, where we have more kind of quick claims data, we see care has returned back to its pre-COVID levels. But we know that if we were to have a tremendous surge in cases or some new variant, that we see disruption and we see tremendous care gaps. We know for some populations that were particularly hard hit, the nursing home population, the dual-eligible population, those that have chronic disease, that we have to think about better strategies than just simple payment reform to really support those populations going forward. The data that we see, that I'm sure the same is true for states, there are key segments of the CMS populations that were kind of most hard hit, and that we have to think about better strategies, payment being one of those, where we can better support, better care for, better coordinate care, particularly for those that were hardest hit by the current pandemic. The second thing I think is true, that I think is a tremendous shift from, say, maybe 10 years ago, is I think the conventional thought process, particularly from the Medicare side, sorry, from the federal side, was that the Medicare program really was the kind of strongest lever going forward. It was the kind of largest program at the time. It had probably the most control to the overall payment systems. We're in a different world today where the state Medicaid programs now are the largest source of total coverage in our country. And from a CMS time perspective, and I think probably is true throughout the federal government, that the challenges being faced by state programs are really the central kind of focus going forward. We saw during the current pandemic a tremendous growth, really, because states really are serving as the kind of safety net to coverage. But today, the states really are the largest programs for total coverage. And so whatever strategies that we choose going forward, we know that states have to drive, that states have to lead. They have grown past the federal Medicare program. So we just can't use Medicare levers going forward. We have to find solutions that are really multi-payer. In some respects, states have much better data, much better information, much better knowledge, not just the payment strategies going forward, but how we want to design care delivery that can help really address systems being better prepared, the most vulnerable populations better protected. CMS has a huge role to play, but given the local nature, the local challenges, that we know that states really are best positioned to drive those strategies.
Thank you, John. Following on that, in terms of guidance to states to how to make their decisions in terms of priorities as effectively as possible, there are a number of ways, obviously, that any state administration can focus their attention. They can focus on certain populations, or they can focus on certain care settings. They can focus on certain conditions. As the system moves from one that is very much oriented around essentially serial services that are provided to one that is more holistic in scope. Do you have any counsel for states as to how they might identify the decision rules in making their investments?
I think a couple of thoughts that have really come from our Center for Innovation team that have studied the work of the past 10 or so years regarding payment reforms, payment models, and a couple of things that the team really has kind of carried forward. Kind of number one is that we see the best evidence for success, the best evidence for sustainability for those models that start with a kind of whole population perspective. The Innovation Center, some very federal, mostly federally focused models, some state models. But when you look at the totality of the savings, the totality of the evidence to date, is models that really start with a kind of population health construct, really assign accountability, not just to a kind of single site or a single specialty, but really the total cost of care perspective. That's where we see the best results, which really makes sense from the standpoint is that when care can be shifted, when care can be delivered in more home-based settings, less intensive settings, when care can be better managed, really throughout the course of treatment, course of time, that we see better quality results, we see better cost savings results. And so I think that is one core learning that we have taken going forward, is that we really want to start with models that CMS promotes going forward that start with a population health perspective. So that's kind of one takeaway. Second is, and I think it's probably obvious to folks here on the line, is that care is more transient today than I think ever before. And so we've seen with COVID flexibilities that CMS promoted, that states promoted, that care can be shifted much more rapidly than maybe public policy thought of during the past 10 years. We've seen with our work around vaccine mandates that we have to think about kind of whole systemness rather than just focusing on kind of one particular site, because workers move, because patients really have multiple stops during their care journey. So I think two broad lessons that we have taken. One is models that start and focus on total population, total cost of care, have the most success for quality improvement, cost savings. Second is focusing just to a single site of care really is not possible anymore, given that care is now practiced similar services in several settings, and patients, workers, workforce move rapidly between those settings more often than ever before.
Thank you, John. I'm going to, as people are sending questions in, I'll turn to them in just a second. But first, one more question that will sort of take us diving into the analytic weeds a little bit. And that is, from a big picture perspective, we know that incentives matter, payment incentives, and we know that measuring matters at some level. On the measuring front, we also know, at least we're learning painfully, that we need to be better in the way we measure performance and move away from the literally thousands of measures now that organizations are reporting on to measures that might be better gauges of system performance at the organizational level and even above that. What are your thoughts about ways in which we can improve our measurement system to help us advance to the goals that you have?
I think it's probably one of the toughest questions that CMS thinks about on its quality side. And I think there's a competing pressure that we face on, do we narrow the set of measures, and do we focus on those measures that can be both Medicare focused, Medicaid focused, and the commercial health programs, versus wanting to make sure that we have better line of sight, better clarity to all services that are delivered to Medicare, Medicaid patients, for example. So I think we have to find the right balance. And I think we have to find the right comfort level for determining which measures for which programs, for which models make the most sense. And so the answer to me really isn't that we cut down measures, but that we have greater line of sight, greater clarity for which measures are most appropriate for which programs. So if we're talking about population health programs, where we want to have broad indications of the general directions on system performance, then I think we absolutely have to become comfortable with narrowing the set of measures, focusing on what's most important to consumers, which probably means focus more on kind of healthcare outcome measures, the CAP surveys. And as we think about the individual services, we're always going to have to pay for, we're always going to have to think about not to dial back those measures, not to send a signal that we're going to reduce measures, but to have greater clarity for the overall purpose. So as CMS is thinking about population health models, particularly those that are more than one payer, we absolutely want to get into a conversation about how we can reduce focus and really think about population health measures, but we are still going to continue to pay for oncology services, for cardiology services, for behavioral health services, and there is absolute pressure, not just to CMS, but to all payers to make sure we're getting the best possible service. So the number of measures may continue to grow, but as we focus on healthcare delivery transformation, population health focus, we are very much committed to narrowing those sets and making sure that we can extend that common set, not just to CMS programs, but to state programs and to private paid programs.
Thank you, John. Turning now to the role of the business community in progress. There are many ways in which business is critical as well to forward motion on the goals of CMS. Obviously, what they negotiate in the way of covered services with various payers, but also as we look at the issues that you've referenced that are community-wide initiatives, whether it's housing or transportation or food assistance, all important to health outcomes, the business community can and really has to be involved for community-wide change. Do you think that, do you see changes in the business community? This is a question from our group here, in terms of their receptivity to engagement, both on the broader outcomes dimension and on the community-wide resource dimension?
I think it's a great question. I think it's one that I'm not sure there's a single answer that would really address the question. I think we, CMS, see kind of multiple perspectives, particularly the private sector that is more and more serving Medicare, Medicaid populations today. So I think the world of CMS is less and less a direct payer, but more and more a payer to third-party entities, plans, Medicare, with the Medicare population, particularly the dual-eligible population, is shifting rapidly from the fee-for-service side to the MA side, the private plan side. Same is true for states. The proportion of the population, particularly higher spends, sicker populations, are shifting rapidly from fee-for-service environments to private Medicaid managed care environments. So there we are seeing tremendous growth in new models, more innovation, particularly for kind of public covered populations that are being served by private sector entities, private health plans. I don't know that we see the same kind of innovation on the private payer side for commercial populations. There are some examples, to be sure, but I think we, CMS, see the most innovations, particularly for those populations who are covered on the Medicare and Medicaid side, which makes sense. The dollar spend is high, relatively higher. The opportunities for improvement relatively higher, but that's just the current perspective. But we are always eager and very excited to hear about, learn about kind of other models and new innovations for non-CMS, non-state population, covered populations.
Thank you, John. Here's a question from John Emerson related to primary health care and the issues around chronic care and disease management programs. And the notion is that many states delegate Medicaid to county or administrative regions. And what are your thoughts about the ways in which we can ensure the services that are most effective and efficient are the end result?
I think it argues that top-down solutions probably are much more constrained, particularly when we think about models of payment where we take voluntary participation. And so in most cases, when CMS tests new models, they're voluntary. And so one of the things that we are trying much harder to do going forward is to be less about here's a model, here's the terms, here's how you participate, and stand back and let people choose to join. And I think the model that we want to get to over time, which is taking more time for us to launch, is starting from a kind of different perspective. To first kind of understand what communities want, need, then to think about ways that we can support. We'll still have to go through the normal channels about payments and participation and making sure that the rules are fair. But I think the question really kind of supports the premise that a top-down solution where, say, CMS or a state says, here's the model that is perfect, participate, and we'll assess 4 years later, probably isn't going to be the right strategy going forward. And so can we turn that around and just say, let's start from community first, in this case, that it could be counties, and begin to think through the best strategies going forward. So our leadership has challenged CMS to say that we're going to make a stronger point and a more proactive point to listen, to understand, to assess. And I think the tension there is that brings in more process, brings in more timeline. But we think today where we are, and given the learnings and given the tremendous variation in need, strategy, focus, that we're going to have to think about more of those kind of community-oriented kind of solutions first, that then national state models can help support. But I think that's going to be the greatest challenge going forward. And I think all of those sort of frameworks that CMS tends to operate in, particularly at a federal perspective, particularly at a Medicare perspective, we have to have consistency, we have to have continuity, we have to have kind of fair processes. But those processes really get challenged when we think about particularly the post-COVID world that had such a disparity in kind of impact and effect throughout the country, that we are being challenged to think about how we first understand and first really take in kind of multiple perspectives before we go out with a new kind of payment model, payment idea. Those are really going to have to be the strategies that we use, that we think will also be the same pressures that states too will face.
Thank you again, John. I know we're winding down in terms of the time available. Let's take, if we can, 2 more questions and then give you the last word to wrap up with any parting thoughts. The next question is, actually pegs off your observation about wanting to make sure that there's close consultation, community involvement, and so forth as priorities are set. I'll just read it to you here. We know that immediate access to trusted known people who then partner across all boundaries works. So inside and outside the clinic doors. How do you think payment and policy can drive these proven structures that move away from office visits and towards seamless immediate access structures?
Well, I think it's a great question. I'm not sure I have a perfect answer, but I think the things that CMS, when we think about a new model, really, I think the hardest question comes up to be, who is going to be the entity that takes the payment? I think sometimes my observation in the kind of payment reform discussion, that sometimes we're hesitant to really kind of think hard about who is the entity that's going to be accountable. Is it a health system? Is it a primary care system? Is it a state? Just some kind of hybrid kind of entity. And I think the reason why that question becomes hard is that there is a lot of competition in the system right now for who is going to control the patient, who is going to manage the patient, who is going to really own the care coordination system. So I think probably we have to become, we collectively, federal government, states, communities, have to be more comfortable really designating who is, what is the accountable entity. And so if we see a world where patient care needs to be delivered more in home-based settings, non-facility-based settings, then it probably means we're going to have to be more comfortable with the facilities, not necessarily being the accountable entities. If we see that we want care to be more community-based, then that probably argues we're going to have to be much more comfortable to make stronger statements towards the investment of new healthcare workers or different kinds of healthcare workers. So I think looking back of how payment reform, particularly from a CMS federal perspective, has evolved, one observation probably we can make is federal policy has been kind of hesitant to sort of declare states who is, what is the accountable entity. I think that's one lesson going forwards that we maybe want to think about, and might be still the greatest challenge that we have, thinking about the right payment design going forward. Who gets paid? How do they get paid? What are their responsibilities? And are they really part of the current healthcare system or kind of something different?
Thank you, John. One final question before we get general observations and wrap up, and it has to do with Cadence. One of the features during the Obama administration was the setting of national targets for the movement toward payment structures that were more comprehensive in nature. Now there are similar questions, not only of the extent to which the system moves away from fee-for-service, but and toward alternative payment models, but also the issue of the cadence and pace at which we, as a nation, move toward a more formal engagement with blended and braiding community-based services and institutional care services or medical care system services. Do you, the question is not for an answer of what the pace is, but do you anticipate setting targets for national or and/or state progress?
I think where you will see CMS is doing a couple things. Number one, setting bolder targets for how we think about healthcare outcomes, and less focus on what is the participation to a given payment model or a given payment methodology. That really to us is the kind of means to the end. And so our targets going forward, goals going forward, be more focused on the endpoints, better care, better quality, more equitable, and recognizing that we need lots of different tools, payment reform being one of those, quality measurement, quality strategy, healthcare delivery system changes, to get us to those ends. But you will see CMS stating its vision for how we think about bigger, bolder goals, really around the end, kind of endpoints, and less focus on statements of goals around the means, but we recognize those means are crucially important to get to the endpoints. And I think the second thing you'll see CMS do is to really support where states want to go. And so we have kind of multiple levers, multiple channels for those conversations, one of which is kind of payment models that come out of the Agency Center for Innovation, but through state waivers, through kind of other mechanisms, that those will be other opportunities that we want to support states, help states, and as they set goals that hopefully we're all kind of pointing in the same direction, that CMS will also support that direction, coming from states, coming from communities, in addition to the national goals that we want to set, really focused on those endpoints, better quality, better cost, more equitable, rather than defining a goal to say we want X% of the population in a certain kind of payment model. Much more focused on the quality goals, the outcome goals, the cost goals, building a healthcare system that is more equitable, building a healthcare system that is more resilient going forward. That's where we want to be helpful.
Thank you, John. Any other parting words for us?
No, it's great to see so many friends and colleagues here on the screen. Our whole team is watching the work that you're doing. We will be eager to see the reports and to see the findings, and it's to us crucially important, very timely, and please know that there is a whole agency that's going to be watching and devouring what this group comes forward with.
Thank you, John. Thanks for your leadership. Thanks for being with us, and a big round of applause from all of us. You can hear the electrons firing across the nation. Thanks.
Goodbye. Good to see you.
Mike, over to you.
Thank you, Michael. Thank you, John. It's great to see you, and great to see you energized being back in a national leadership position. It is now my pleasure to introduce the moderator for our first panel. Josh Sharfstein is a friend and physician who is Vice Dean for Public Health Practice and Community Engagement and Professor of Practice and Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Previously, Josh also served in the public sector as Secretary of Maryland's Department of Health and Mental Hygiene and as as Principal Deputy Commissioner of the U.S. Food and Drug Administration, as well as Health Commissioner of Baltimore City. In all of those positions, he's pursued creative solutions to longstanding problems and challenges in both public health and the care delivery system, including drug overdose deaths, infant mortality, and unsafe consumer products and school failure. So very much in the mold of thinking about whole community health as he is fond of reminding us, we need to think about communities and not just individuals. Josh is a member of the National Academy of Medicine and the National Academy of Public Administration. Josh, let me turn it over to you to start us off.
Great. Well, thanks so much, Mai, and thanks to Michael McGinnis and John Blum for getting this started so well. We're going to have a great panel about the workforce, and I will invite the panelists to turn their cameras on as I give a couple remarks and then introduce them. It's really exciting. I heard from Jonathan Blum that CMS wants to do things differently, that both the pandemic and the impact of the pandemic have led to a lot of rethinking of different approaches that the agency has taken, that they want to prioritize Medicaid, which now covers so many people in this country. They want to focus on population health, not just the health of individuals, one patient at a time. And they really care about equity. And they want to advance equity and particularly focus on communities of color, rural areas that have fallen short in many ways in terms of getting resources and making progress in health. In order to do things differently, in order to get different outcomes, in order to pursue those goals, CMS is going to have to think differently about the healthcare system. And in particular, CMS is going to have to think about who works in the healthcare system. And that really brings us to workforce. And I'll just very quickly tell one story about a CEO in Maryland who I met with. He'd been a CEO for a long time of a hospital in Maryland. When we switched payment and we really wanted to focus on population health, we went from fee-for-service payment to global budgets. And I came to see him and he said, you know, I don't know if I'm right for this job anymore. We need new people with different perspectives in. And I said, why would you say that? And he said, the whole time I've been in the hospital industry, I walk to my office through the cafeteria. And I know how our hospital is doing by how many people are in line in the cafeteria. And if there are a lot of people in line in the cafeteria, we're doing well financially. Now, under a global budget, a different set of incentives, all this talk about population health, I don't know, based on my walk through the cafeteria, whether or not the hospital is doing well or what I'm supposed to be doing. And I think we need new people, different people to think about this challenge. So, you know, I think he was like many years into his career. It was a natural time for him to retire, and he did retire. And I think that the idea is that there are opportunities now to make a difference, but with not only different people, sometimes some people, you know, adapt, but also different kinds of people working in the healthcare system. And we have just a phenomenal group of people here to talk about that. I will give a bit of an introduction to them, and then we'll have some initial comments from each of them, and then we'll go to Q&A. So first, I'm so delighted that we have Denise Octavius Smith here. She is the founding executive director of the National Association of Community Health Workers. Among many different positions and accolades, she is a visiting scholar at Harvard Medical School and a Robert Wood Johnson Culture of Health leader. During the pandemic, she co-founded the Community-Based Workforce Alliance and the Vaccine Equity Cooperative. She is a community health worker and certified patient navigator herself. Thank you so much for coming, Denise. We also have Alex Briscoe. He is a principal at the California Children's Trust. Recently, he was the director of the Alameda County Healthcare Services Administration, where he led one of the state's largest public health systems, including health and hospital systems, public health, behavioral health, and environmental health. He served on the Alameda First 5 Commission, the Alameda Alliance, and the Kaiser Commission on Medicaid and the Uninsured. He's a mental health practitioner specializing in adolescent and youth development. Our third speaker will be Bonnie Silva. She is the director of the Office of Community Living at the Colorado Department of Healthcare Policy and Financing. And there she guides policy, strategy, and system redesign. This office in Colorado administers long-term services and support benefits for people with physical, intellectual, and developmental disabilities, including people who includes long-term services and supports for people living in their home as well as services provided by nursing facilities. Finally, we have Doug Eby. He's the Vice President of Medical Services. I hope I got your name right, Doug. For South Central Foundation's Malcolm Baldrige Award-winning NUCA system of care. He is a physician executive who has extensively worked with the Institute for Healthcare Improvement and has spent more than 20 years working in support of Alaska Native leadership as they created an innovative and successful model of healthcare delivery. So for each of you, we're gonna have some initial comments. I'd like to ask you to address, who do we need more in healthcare? What kind of person working in healthcare do we need more of? And what are the opportunities to actually make that happen? Start with you, Denise. I think we'll do about 7 or 8 minutes per person.
Yes, fantastic. Thank you so much for having me. I'm not sure if Togi's going to share slides. Okay, fantastic. So I bring you greetings from Hartford, Connecticut and the National Association of Community Health Workers. We were founded in April 2019 as a national nonprofit, uniting this very diverse workforce so that we can come together for collective movement to support our communities to achieve health equity and social justice. Next slide, please. So in the time I have here, I want to really provide a level set as the pandemic has provided sort of unprecedented opportunity to discuss the gaps and opportunities to rebuild the public health workforce and to achieve racial equity. But we found that little is actually known about this very diverse workforce. So if we believe we are going to partner with community health workers to address a growing and persistent public health worker shortage, as Joshua mentioned, the PH Wins reports from de Beaumont indicate that we have an aging public health workforce, a workforce that is mostly white, mostly female. If we're going to begin to chip away at the weaknesses in our pandemic readiness, and in particular, I like to say that we had a clinical response to the pandemic. We had a public health response to the pandemic. We can talk about supply chain gaps, infrastructure gaps, lack of investment, but we did not have a community level response. If we want to reduce cost and disease by prioritizing the social drivers of well-being or the social determinants of health and achieve racial equity, then CHWs certainly have a role. Next slide, please. So I want to go through quickly 6 pillars that are important grounding for Joshua's first question, which is, who are we talking about and why are CHWs part of this discussion? Number one, we are a unique workforce. We have a definition and policies that articulate our unique role going back 20 years in the American Public Health Association. We have a US Department of Labor classification and we're recognized as of 2010 as health professionals in the Affordable Care Act. We have endorsed across our profession unique and unduplicated core competencies. And during the early months of the pandemic, the US Department of Homeland Security classified CHWs, among many other professionals, as essential critical infrastructure workers. However, this guidance, which was distributed to all states, was not adopted by all states. And we saw during the early months of contact tracing sort of design and the beginnings of sort of addressing the social determinants of mental health issues of people as our communities closed down, as economies suffered, that we didn't have the right workforce on the front lines integrated into our task forces and our response. Next slide, please. Number 2, we are a community-based workforce. This is just a snapshot of national data from NACHWA. We have membership in 48 states currently, but this has been confirmed by many other studies that the majority of this workforce is not working in hospitals, health systems, FQHCs, or health plans, local or state health departments, but it are in fact in community-based organizations. And so some of the messaging and the priorities, the sort of reconciliation that John Blum was sharing are really critical here, that we have to develop infrastructure through contracts, funding, authentic partnership with community-based organizations. the sense of community groundedness is at the heart of the way in which CHWs operate. And it's central to these efforts and priorities around clinical and community integration. Next slide, please. Number 3, CHWs are a historical and a diverse workforce. Our origin in the United States does not begin when FQHC started to find their place and establishment in our health and service delivery. We are known by dozens and dozens of different titles, which makes it often difficult for even states to begin to develop workforce initiatives and plans, career ladders, and training for our workforce, because we're known not only by our titles, but by our cultural alignment and identities. So we are known as outreach workers or early intervention specialists, navigators, care coordinators, but we are also known as promotoras, as peers, as community health representatives, as aunties. However, it is that diversity which is the strength and essential to what we are trying to do now in COVID response and the rebuild. And I'll just summarize it this way. We look like, we live like, we are often survivors of or dealing with the same chronic diseases and structural barriers to health and well-being as those where we live and serve. Next slide, please. So just 3 more pillars that I want to address here. Number 4, we are already a cross-sector workforce. So everything that we think about what families and communities need to achieve whole health and well-being is really from a cross-sector perspective. We often don't collect data on CHWs that reflect the fact that we are working in housing and immigration, as well as gender-specific health issues, maternal and child health, workforce development programs, social welfare, but national data from our membership and many other studies reflects that work. What's also important to note is that as we begin to innovate, it's important to understand that developing these partnerships across sector helps us create and sort of clarify all of the informal networks that our workforce, myself included, have to apply to address the whole health needs of communities. Often this data is not collected the way that we are working informally across sectors. So we have missed opportunity not only for funding, but for measurement as well. Next slide, please. Just 2 more here. Number 5, we are a proven workforce. And I'll just say, I'll reference and maybe throw into the chat this brief that was released by ASTHO and NACHWA in January 2020. So the pandemic sort of overshadowed its release, but it sort of summarizes over 6 decades of documented evidence of our effectiveness across a variety of different programs and services and through a number of different randomized controlled trials, systematic reviews, et cetera. We are increasingly being recognized for our contributions to address racial health equity and the social determinants of health. And the CDC, we're sort of proud to partner with doing some early national study in that area over this past year. And a final slide, I believe. Thank you. And finally, we're a precarious workforce. As we build now in this unprecedented moment of investment, and that's really what I call it, a moment, we have to figure out if this is going to be a movement to realign our structures for all populations. And part of that means we drive equity in supporting the advancement and sustainability of the workforce itself. CHWs are majority female. We are among the lowest paid of all public health professionals. The nature of our work brings sort of asymmetric risk for violence, for communicable disease, for secondary trauma. And across our states and federal agencies, we have very inconsistent policies or even a recognition of our professional identity. In other words, it's difficult to develop strategy at the state level when you don't have policies among public and private professionals and organizations that are clear. Finally, persistent lack of sustainability, and we look at that holistically, not only to include the financing, right, the reimbursement codes or the payment models, but also recruitment, training, legislation, professional development. And then lastly, and this is an incredible opportunity that I really hope states take advantage of, it's really to collect the data that is needed right now during this infusion of COVID dollars, where we will see tens of thousands of frontline workers hired, that states begin to pivot and consider their long-term aims to address the social determinants of health, maternal and child health, health equity, access to care, by gathering data about the workforce itself, so that that data can be mapped, so that we can study the demographics of the workforce, so that we can create pipeline programs to rebuild our public health infrastructure. Thank you so much, Josh, for the time, and I look forward to the discussion.
Great, thanks so much, Denise. That was really absolutely terrific. Before you go though, I wanna sneak in one question for you, which is recognizing all these challenges, is there some particular opportunity that you would call attention to now that is maybe shining a brighter light on the potential for community health workers to make an impact these days?
Well, certainly we have a number of funding streams that are active, which are opportunities over the next 2 to 4 years to pivot to some of these sustainability initiatives. The CDC has the 2109. We just saw with the simultaneous release of the Health Equity Task Force recommendations, about $780 million to continue funding for COVID work that explicitly names community health representatives, CBOs, and community health workers. So these are opportunities, again, for states to consider these dollars not for the moment, but to really bring in cross-sector partners, public and private stakeholders, to say, how can we pivot to the sort of long-term infrastructure that we need to sustain the workforce. So I think many opportunities present themselves. They're not necessarily funded in consideration of sustainability, but I think we should redeem the time and move in those directions.
Got it, so well stated, thank you very much. Okay, Alex, over to you.
Hi, everybody. Sorry, I'm putting a link in the chat to 4 new provider classes just approved in California's Medicaid plan. But I was also trying to say how amazing Denise is and what a pleasure it is to listen to her. So I think the NAS crew is going to put some slides up as they do. NAM crew is going to put some slides up as they do. I will say just briefly, a mentor of mine once said that we're all better when we act on the exhale. So I'm going to do that for a second. Oh, please share the slides yourself. Great, I will. Please give me 1 second, y'all, while I pull it up. And I'm here to talk a little bit about how California is approaching striking increases in utilization and acuity for children's mental health. I will say as well that I come to this work after about 25 years of direct clinical service and support in high acuity settings for children, in emergency departments, in juvenile justice, and a number of other safety net Medicaid settings. Sorry, one more share moment.
Take your time. It's always important to share the right file. And you've been on Zoom for 18 months. You've seen everything.
Thank you, Joshua. So I'm going to move quickly for the first few set of slides because to be respectful of the content of today, I really do want to focus on some of the expanded provider class opportunities that offer a chance for us to transform Medicaid, not only in California, but across the nation. But before I do, I have to name the fact that mental health and substance abuse disorders are the leading cost driver by just about any standard measure, and it's unique to California, unique to America. And the reason I raise that is the medical model cannot be the answer. You don't treat away poverty, you don't treat away racism. And that's one of the reasons that today's conversation around reimagining a provider class in Medicaid is so essential and important to changing outcomes, particularly in children's mental health. And there is a crisis in children's mental health. It's a crisis that preceded the pandemic. We are now in whatever you call a crisis that you poured a bunch of gasoline on and lit it on fire. In the decade before the pandemic, we saw a 104% increase in inpatient admissions, a 50% increase in mental health hospital days. Children in the California Healthy Kids Survey told us that they were needing more. And despite California's progressive politics, we rank 43rd in the nation in behavioral health screening. I'll give you some other data about sort of the thin progressive veneer of California's Medicaid program. We are the largest Medicaid program in the nation. Almost 6 million children are now enrolled in it. And of course, we must disaggregate any of the data I just showed you, however troubling it is, by race and class. Making healing-centered systems isn't just about some of the financing tricks I'm about to talk about. It actually has to be reimagining behavioral health, not as a response to pathology, but as a support for healthy development. So if I spontaneously combust and you take nothing else from what I'm about to say, I hope you can join me in a reimagining of what it means to support the social and emotional health of children. And one way to hold that is we should formally and directly remove diagnostic criteria as a prerequisite for reimbursement across all payment systems in Medicaid. You should have to have a diagnosis to qualify for care and support. The same way you don't have to have a diagnosis to qualify for a measles, mumps, or rubella vaccination. We made a decision in the EPSDT entitlement in a change we did to the Social Security Act in 1967 that young people must not, they have their own special medical necessity criteria in Medicaid. It is time, way past time, we applied that to behavioral health and infused it with the principles of social justice and health equity that we are coming to consciousness about. COVID made it a lot worse for kids. You've probably seen the CDC data. If you actually look at some of our level 1 pediatric trauma centers in California and combine that first data with the impact of COVID, you will see a 1,700% increase in inpatient admissions. And we also know that during the pandemic, we saw a 34% decrease in access to claims. So basically, we know that our current system wasn't functioning before the pandemic and we made it a lot worse. The medical model isn't the answer as well from just some traditional like plumbing questions, right? 75% of mental illness manifests between 10 and 24. That's when kids use the primary care doctor the least. And we got here because we have a very poor understanding of what behavioral health is and how to do it. We've imprisoned it in a traditional medical model, which will simply not work. These slides will be available afterwards. And I know I'm talking fast, but I'd like to get to some of the solutions on workforce. Medicaid is essential because it now covers almost 6 out of 10 children in the state of California, a 30% increase. We rolled S-CHIP in. We did a pretty good job finding those mamas and babies who are eligible but not enrolled during the ACA. So our Medicaid rolls have increased dramatically, but only 5% of all children in Medicaid get access to anything at all, like are touched by our mental health system, and only 3% are in ongoing care as measured by 3 or more visits in a calendar year. So the leading cost driver, in fact, in this same period of time, suicide has leapfrogged car wrecks and cancer as a cause of death. We are in a socially constructed epidemic of despair, and our healthcare system is not prepared to respond unless we reimagine what behavioral health is and who does the work. So the essential solution we are proposing in California is the shifting of agency and power. Agency as defined by who does the work, power as defined by who gets paid to do it. And it's well past time. California ranks in the 3rd of the nation in spending per beneficiary. I won't even do the rest of the data. 48th in the nation in access to needed mental health care for kids per both the Commonwealth Club and Mental Health America. And this is one of the great challenges of our systems. It was interesting to hear the previous speaker speak about what does it mean to have access to an entitlement in a capitated system. As all of us have shifted to a managed care delivery system, we have to acknowledge the fact that kids and frankly, mental health is not privileged in these systems because of our poor understanding of how to qualify children for care. That goes back to the definition of medical necessity. It goes back to the need to remove diagnosis as a prerequisite for care. Schools are essential actors for that period of time, 10 to 24, when children don't go to the doctor via periodicity requirements for Medicaid, but also because the finances align. You could distill my entire career to hunting for non-federal dollars that are eligible for a federal match. Those of us who've led local public safety net systems are always looking for that non-federal dollar eligible for a federal match, and schools have a bunch of them. So basically, schools are not only the right clinical setting to provide access to care for children for behavioral health, they also have access to that essential greasing up the skids, which is the non-federal dollar to claim against. California is doing a bunch of stuff. We have political will. Californians say this is the most important issue. There's an emerging consensus and consciousness that the kids aren't okay, that we should be doing something more. You're seeing this at the national level, both in the recent CDC data, but the statement by the American Academy of Pediatrics and the Children's Hospital Association of a national state of emergency on children's behavioral health. And California has responded directly through a $4.4 billion youth behavioral health initiative, over $15 billion of direct funding to schools to support the social and emotional health of children. And of course, both of those have to be intermingled with the federal stimulus funds that also provide significant new opportunity for redesigning our social and emotional supports for children. I will say as an editorial comment that the sort of serial entrepreneurialism of some of these investments is frustrating for some of us who've been Medicaid folks, meaning one-time funds don't answer it. We should be looking at FMAP strategies. A dramatic enhancement to FMAP for children's behavioral health based on a maintenance of effort requirement is one strategy I think the Fed should pursue. Make states can maintain their existing level of funding for children's behavioral health, but any new service on top of what is currently funded could be funded at 100% for the next 3 years and then titrated down to 90% ongoing, the same way we did with the expanded MAGI population. Such a strategy is a clearly effective tool, and I think it should be done for children's behavioral health. These are the details of the $4.4 billion Youth Behavioral Health Initiative. I will highlight 4 quickly. The first is the Service Behavioral Health Virtual Service Platform. This is a referral tool for all children, regardless of payer source. There's $950 million of new investments to start behavioral health programs in schools. We also created something called the Dyadic Behavioral Health Benefit, which removes diagnosis and allows for the reimbursement of PCIT, parent-child interaction therapy, healthy steps, trauma-informed cognitive behavioral therapy, and Project Dulce, the 4 dominant models of integrated behavioral health in pediatric primary care 0 to 5. And to our today's conversation, we also created a new class in the Medicaid program called Behavioral Health Coaches in Schools, meant to extend access to support. So I'll wrap, Joshua, just to end our comments here. These investments represents the single largest investment in California's history in children and youth. It's a lot, it's messy, so that has to be named. Remove diagnosis is the essential action. Center pediatric primary care, and build a health system for people by expanding the provider classes. I put a link in the chat. And finally, finance, sustain, and scale via Medicaid reform and the identification of new sources of non-federal dollars to fully leverage the EPSDT entitlement. I'll stop there. Joshua.
Super, thank you. I had not really appreciated the scale of the ambition on this in California. Really terrific presentation. One quick question for you. Where would you look to see the impact that you want to have with this investment? What are the, you give an example of, okay, we're going to spend this money, we're going to, pull in all these other kinds of providers. Where will that show up? What should we see?
Oh, well, absolutely in traditional outcome measures, including a reduction of inpatient admissions to the emergency department, a decline in self-injury and suicidality. So traditional healthcare system measures, but maybe more importantly, we'd like to see the direct benefit of the Medicaid program derived to impacted communities, meaning we could legitimately suggest that over the next 5 years, between 5,000 and 10,000 people currently receiving Medicaid will receive full-time family-sustaining employment to serve the Medicaid population. That's really the invitation of today's webinar to me, is how do we flip the script and look at safety net populations not as problems, but as solutions? How can we leverage the wisdom and intelligence of lived and learned experience to transform our Medicaid system and shift power and agency while we do so?
Fantastic, thank you so much. Okay, Bonnie, over to you.
Great, thank you, Joshua, and thank you to the members of NAM for inviting me to be a part of such an esteemed panel. Hi, everyone. I'm Bonnie Silva. I serve as the Director of Office of Community Living at the Colorado Department of Healthcare Policy and Financing. If we can go to the next slide, please. So just to ground ourselves in the conversation, we have talked a lot about the workers. I'm going to talk a little bit about the people. And I believe that unless or until we value the people, it'll be really hard to elevate the workforces where we have critical shortages. So within the Office of Community Living, in terms of who we're talking about here, we serve nearly 76,000 Coloradans with disabilities. We serve folks from the day that they're born to the day that that they die across a variety of settings. So in their homes, in their communities, their place of employment, through quasi-managed care programs called Program for All Inclusive Care for the Elderly, and in institutional settings such as nursing facilities. Next slide, please. So I want to talk a bit about the impact of COVID-19 on long-term services and supports. And what we experienced in Colorado was mirrored in other states nationally, right? The pandemic had a disproportionate impact, certainly on older adults, but especially those older adults and people with disabilities who resided in congregate settings like nursing facilities or in group homes. And so we had cracks in a system that was created 50 plus years ago to provide people long-term care, and those cracks are now chasms. Next slide, please. So in Colorado, when we very quickly realized that this pandemic would really fall on the front lines of community-based organizations, initially we were so very focused on hospitals, and we had to really pivot our response to focus on those residential care settings. So we created a cross-state agency team that made sure that critical resources such as staffing, PPE distribution, were at the forefront of our planning and implementation for our COVID-19 response. We focused pretty hard on regulatory flexibilities because we're government and that's what we offer and that's what we bring to the table. So wherever virtual service delivery could be allowed, we went there. We also looked at how we could loosen qualifications for these workers and these providers as a way to quickly expedite the onboarding of workforce that was critically needed. And then of course there was funding. We distributed nearly $150 million from a state level directly to these providers. We saw that costs were pretty significantly increasing in ways that our Medicaid reimbursement did not support. So whether that was, paying for overtime, cost of PPE, the cost to create, COVID safe environments were pretty significant for an already fairly fragile workforce and provider base. Next slide, please. And I know I'm also talking fast. Slides will be available. I do want to spend the bulk of my comments for the end of this presentation. So we have a tremendous opportunity with federal financing, and Alex so aptly named that one-time funding is not enough, but darn it, it is going to get us started on a whole lot. So we really looked at the American Rescue Plan Act here in Colorado and how we could invest that in our system to close some of those cracks and those chasms that were created. If we can go to the next slide, please. So our future is we want high quality services in the place that the person wants to live. So that means aging in place, services in people's communities that meet their needs and their desires. We want to make sure that services are not hard to access and people don't get entangled in an eligibility sort of a puzzle that they can't figure out. And we want to make sure that we have a strong, high performing quality provider network. If you can go to the next slide, please. So in Colorado, what the American Rescue Plan Act means is we have over $500 million in one-time funding that we can invest to strengthen our home and community-based system. For us, that meant we had 8 overarching priorities. Within these 8 overarching priorities, we have 67 projects. I can appreciate also Alex's comment around serial entrepreneurship, and we worked really hard to not reinvent the wheel here. We know that we have a lot of opportunity within our system to expedite existing initiatives, but also to actually create something new while also looking at, long-term federal financing. So I am not going to go through all 67 initiatives. I am going to link in the chat a copy of our spending plan, but I want to highlight a few. So when we look at support post-COVID response and recovery, one of the things that we're looking at is how we can implement pay for performance in long-term care. That is something that is not new to the medical community. How do we take those financing mechanisms and let really strong, high-quality providers be elevated and share in some of the cost benefits of providing that quality care? For example, we were looking at things like taking evidence-based models such as Capable, where for the older adult population, they paired older adults with a handyman, a social worker, and helped them mitigate and in some cases eliminate the need for Medicaid enrollment and more intensive services. How do we expand those types of models to other populations and come up with a sustainable Medicaid reimbursement for it? We also have $78 million in investments for technology. So really looking at how long-term care can be brought to the table when we're talking about remote delivery and interoperability between the medical system and the long-term care system. If we can go to the next slide, please. Also just want to highlight, how are we spending that over 500 million? So you can see the vast majority of these dollars are really focused towards workforce. So we have the immediate infusion of funding. These are incredibly low wage workers. How do we, raise the water table, if you will, for what they are being paid to do such important work, while also investing in the data infrastructure, I think that Denise talked about, of, who are these workers and how do we develop those medium and longer term strategies that really ensure that we will have a workforce now and into the future. Again, set over $78 million in technology and 63 million to really reinvent how we provide long-term care, moving away from those high density congregate settings to aging in place, whole person, community-based care. All right, I'm going to keep us moving because I know we have a lot to cover still. So Joshua, back to you, and I will put a link in the chat to our spending plan.
Thank you so much, Bonnie. Question for you: How much do you think this evolving discussion reflects an understanding of the need for this set of services to do things differently, because of infectious disease in particular? I mean, did COVID provide an extra boost for this? Not the money from COVID, but just COVID itself.
Yeah, what COVID highlighted or sparked, if you will, is a national discussion for how we care for people as they age in or become disabled. And I think there was a natural inclination to just move people into nursing facilities as their care needs advanced. And what we saw is that can be a really dangerous strategy when you have people with really complex medical needs in a high density setting for any infectious disease. COVID, because we couldn't see it, was particularly challenging. And so how do we change that as we move forward? What are the different models of care that we need to consider?
Got it. So, I mean, in a way, you've got the economic opportunity of short-term funding, but also a little bit of capturing people's attention because it was so clear that it'd be better not to have everybody concentrated if possible.
Yes, absolutely.
Great. Okay, Doug, over to you. Looking forward to hearing about the model you're going to talk about.
All right. Like everyone else, I'm going to talk too fast and cover too much material, but I'm pretty sure after listening to the others that we should make Denise the head of CMS and hire Alex and Bonnie as her technical advisors, and we'd solve a lot of issues right there. So anybody that's in support would just do that, and then the rest of this won't matter. All right, so I had the incredible privilege of working here at the Alaska Native Medical Center for over 30 years and in leadership for over 25 years. And it is indeed an honor because this is a community-owned, community-driven, community-designed system of which I have just helped support the journey. And it was, as mentioned, we've won the National Malcolm Baldrige Award twice, and they don't give that to you for being cute or from Alaska or being a native system. We and our sister company that is more of the hospital-based part of the system, together we employ almost 6,000 people and provide support to somewhere between 250 and 300,000 people, depending how you count, and do everything from water and sanitation and public health through supportive housing, through residential treatment, and all the way up to primary care, optometry, physical medicine, and a tertiary care hospital with 180 beds and all the subspecialists in the ICU, NICU, PICU, robots, and all the other stents and all the other stuff modern medicine can do. So it's a complete vertically integrated system driven by the community. When we took over 25 years ago, the pace of change dramatically increased, and we really have become consumer design and consumer driven. And it's resulted in amazing things, dramatic reductions in per capita cost, dramatic improvements in health outcomes, and hugely improved satisfaction scores by people providing services and receiving services. So it really is the whole quadruple aim or triple aim, whichever you want to talk about. And the other thing I would say is, we, as some of the speakers have said, we know what works. And Jonathan Blum, the CMS administrator who spoke just before us, said what works. I mean, people know what works. What works is immediate access to someone you know and trust, who then partners with you and helps you navigate, coaches, supports you through the different categories of medical services that you need to get to. And when you do that, costs plummet and outcomes dramatically improve. The problem is that's not an institution-centric, provider-centric medical model. And so it's not what's paid for, and it's not what people know how to put in place. And if anyone thinks moving to a single payer system will solve everything, they're wrong. We do consulting and advising all around the world. And in fact, we're most popular in single payer systems. And the problem with single payer systems all around the world is they still trust their medical people to do what they were trained to do, which means the fragmented medical model is firmly in place even in single payer systems all around the world, which of course requires you to make a massive investment as a consumer, right? Even in community and primary care services, the idea is that the patient, what you call the patient, what we call the customer owner, has to call and make an appointment, then they have to wait, then they have to take off of work, then they have to get transportation and childcare, then they have to sit in your waiting room, then they have to go through your rituals and processes that must add religious meaning, because I don't know why else we do half of them. And then they get a few minutes of a provider's time who says, here's a diagnosis, here's a treatment plan. And by the way, if you don't do what I tell you to do, we'll call you non-compliant, in our paternalistic, judgmental, horrible way of providing services. So by the time you're a consumer in that system, you've invested a half a day of time, energy, and time off of work, if you can even do that. And then you get seen in our holy empire and our holy institutions. It's this thing called an office visit. And so you've got this massive investment, which means, of course, you want labs and x-rays and pharmaceuticals, because you got this massive investment, if you could even get there to begin with. So basically, that's a 1-minute version of why the medical model completely sucks. And it's not going to get us to health and well-being at a community level, because it's just wrong. It segments people into diseases and organs, and then it makes you see them in our institutions for the convenience of our staff, with highly trained professionals dictating the terms of the interaction, the conversation, the language, the plans, and then judges everyone non-compliant. It's complete and utter bullshit. And the fact that it also segregates behavioral health into something separate is also completely dumb. There's just health, and there's these things we call behavioral health, but that's just health, and it's all part of one package. So we inherited a medical system and have evolved from there. And so that's where I'm going to talk from. But we've created a system that provides service when, where, and how they want it, with people who they are in trusted first name relationship with, and it just changes the whole game. In order to do this, though, we've had to invest 10 times as much in intensive customer owner listening and voice. We've had to invest 10 times as much in improvement capability as a usual health system, 10 times as much in what people call behavioral health, 10 times as much in workforce retraining and development and that sort of thing, and 10 times as much in infrastructure. And this is news to healthcare, because they think they got a fully trained workforce coming out of professional schools, and all they need to do is put them to work and they'll do the right thing, which is completely false premise, because the paradigm in which they are trained is just completely wrong. All right.
Good. I'm going to break in just for a second to say you are on a great roll. I just want to say you got about 10 minutes, because I want to make sure we have time for discussion.
Next slide.
Okay.
We're getting to workforce right now. So the reality is this slide, which is the customer owners or the patients are in charge for 80% of what happens in healthcare, all chronic conditions. And this is where the major costs are in healthcare these days: diabetes, congestive heart failure, depression, anxiety, all these things. And they're in control. They decide whether to get their meds. They decide where they go, what they do, what they eat, how they handle their stresses, all of those kind of things, which means the primary service we must deliver is influence. And if we don't do influence, we haven't added value. If they don't do something different after leaving our presence, we have not changed the course of their lives, which means just diagnosis and treatment and pharmaceuticals are just the beginning. They have to actually do something, which means the core product is influencing, which means your workforce must come from the community you're trying to influence. Otherwise, you will be an outsider trying to influence with minimal impact, which means the entire workforce needs to be rethought. Next. In our system, we started with a medical system, and so we still have a lot of medical people. This is what the super powerful primary care system looks like in a diagram, the customer owner family in the middle. The immediately, for over 20 years now, we've guaranteed same-day access by phone, email, text, video, however you want to connect to us, which means even before COVID, we were at 70 to 80% asynchronous and virtual. Only a small percentage was in person in an exam room. And we make available to you primary care provider, case manager, case management support. We have behaviorists. Our massive behavioral health program are behaviorists. They're just in the primary care setting and part of the primary care team like anyone else. And then we pull in all kinds of expertise. So we pull in midwives and dietitians and psychiatrists and HIV experts and chronic pain experts who do not have separate schedules. They're just part of the team and expertise available to pull in at any time whenever people are needed. We've fully incorporated pregnancy and early childhood. All newborns and children are seen in this nest environment, and then we pull in the pediatric expertise. And the fact that anyone separates prenatal care from early childhood is just dumb. And I've heard all the speakers so far talk about birth onwards. Well, life happens way before birth, and separating prenatal and the focusing on the nest during the pre-pregnancy and pregnancy time and connecting that to early childhood mental health and infant care and so forth is completely mandatory if you're going to change the trajectory of all kinds of things. Next. And then we pull in all kinds of experts to help support this. We got in the primary care setting, we've got chronic pain, physicians, psychiatrists, physical therapists, complexity, adult complexity, peds, HIV, all these different specialists are physically available and just are pulled in as they're needed. Everything pulls to where the person is. And then there are lots and lots of people doing home visiting, doing lots of virtual things and so forth. It's all built around what they want, when, where, and how they want it to people who know them. Next. Behavioral health is literally everywhere in our system, and we do a ton of lived expertise stuff, talking circles, learning circles, family wellness warriors. We have programs to break the cycles of violence, generational cycles of violence, and completely rebuild the paradigm on which the nest or the family, their extended family lives. And then we reteach and retrain parenting and multi-generational wellness and all of that. We don't expect them to go out and find it on their own somewhere. Next. So really at the base of everything is this idea of being in shared responsibility together. We partner, and next, and it's all done in the context of knowing the story of the person and connecting into their story. So part of our redefinition of workforce is we do something called core concepts, which is retraining every one of our staff, whether it's the custodian, the lay worker, the community health worker, or the doctor, or the nurse. They all go through this 3-day training, which teaches them how to coach, advise, be in partnership, and connect in story, skills that are not trained in our professional schools, but are the core competencies we expect from our entire workforce. Next. And then in villages, about 80% of the population we support is urban and semi-urban, but 20% are in villages. And in villages, we have a completely village-specific workforce, and there's a lot to learn from this. This gets back to the first speaker, Denise, and community health workers. So in our villages, we have community health aides, behavioral health aides, dental health aides, customer service representatives, so like mini medical, mini dental, mini behavioral health, and mini social workers, all drawn from the village that then we train and support and then provide all day long immediate access professional support from the urban environments. And it's the only way we're ever going to succeed in rural and remote locations across this country is to replicate something like this that exists in our system. And then we trust local governance to do all of the social fabric work, and we provide the sort of technical, clinical, behavioral expertise in partnership with the locally run community-based services. Next. COVID, unfortunately, people think they transformed because of COVID, but really almost everyone did was rebuild the office visit in the virtual space using the same components of the office visit and still the same professional-centric paradigm. So basically, COVID did very little to actually transform, no matter what people tell you. It really did very little to transform modern medicine, which is really sad because it was an incredible opportunity to do amazing transformational work. We felt kind of prepared because we were already in the virtual space doing things the way people wanted them, when, where, and how they wanted it, and we didn't have to make you come in the office to begin with. Next. Things we're working on right now include all this list here. I'll just highlight a couple. One is the Aging Well initiative. So starting from age 40 onward, doing anticipatory guidance and partnering with people, letting them drive and us respond, but helping them know predictively what's going to be happening, and a huge emphasis on mentation, so the whole dementia and all that kind of stuff as people age, and of course the massive overuse of polypharmacy in elderly people. So it's a huge initiative there. The one I want to highlight, those new generations where, again, from preconception through pregnancy, birth, and early childhood is a single episode of care with parent partners who then involve themselves in the nest and the health of the nest, multi-generational sort of approach. Anyone who deals with children in isolation from the nest within which they are created, born, and live is ridiculous, because that's what actually shapes most of what happens with them. All right, and the other thing about this list, if you look at this list and understand what we're doing in each of these things that we're rebuilding at this point, none of them are office visit centric or physician centric. They're primarily done by alternative workforces and teams and so forth, but connected. Nothing we do is unconnected from the hub. Next. So there you go. That's my extremely fast summary of 25 years of customer-driven, customer-designed, complete rethinking of workforce, retraining of workforce, what skills and abilities are. And once again, if you haven't influenced them, and if they don't do something different when they go home, you have not added value to them. And this medical arrogance that says, we'll give you a diagnosis, a treatment plan, and then judge you non-compliant when you don't follow what we told you to do, is the ultimate of professional-centric, institution-centric medical model arrogance. And it's just completely horribly wrong. The question is whether we are going to become compliant with what they need, when, where, and how they want and need it, which means in homes, in the virtual space, phone, text, email, all day long, every day, to people that they know and trust.
Great.
And there you go.
Thank you, Doug. That was terrific. And a quick question for follow-up for you. We walk into your health system. What's the first thing, or what's something very early on we'll notice that's different?
Yeah, so first of all, you used the word walk in, and that's just wrong, because we need to be available to them when, where, and how they want us to be available to them. And this is a communication and relationship business. We are a service industry. We are not a manufacturing industry. So the idea you have to come to our place is arrogance. I mean, it's institutional, professional arrogance and ridiculous. They are living their lives the best they know how to live them. And we need to weave our service knowledge and expertise into their lives on their terms, which means the vast majority of what we do needs to be text, email, video, phone. And the walk into our institution piece ought to be a tiny minority of what we do. And in fact, we need to be sending people into their environments, even when physical contact is needed, as much as possible. So when you do walk in our facilities, I will say, especially our larger facilities have massive gathering community centers as a centerpiece. So we have these large places where there are people selling handcrafts and selling food and connecting with each other and telling story. Often there's music happening. And so our entryways are actually community centers for many multiple purposes. And then the medical stuff is kind of the next layer when you go there. And everything's designed to feel comfortable, that they're in their space, they're not in our space. And there's a massive effort into what that takes on. I give lots of lectures on facility design and space design, because if you get that wrong, you're completely screwed up. And some of the most important stuff is how you do team spaces. So for example, for over 20 years, we've de-officed everyone. There's not a private office for me or anyone else in any of our clinical care facilities. It's all, and there's no doctor parking space and no doctor's offices and none of that stuff. It's all integrated team members all sitting and working together. Again, primarily interacting in the virtual space.
Great, excellent. Well, I think some people sometimes hold back saying what they really think on Zoom, but I do not think that is your problem, Doug. I thought that was very direct.
Luckily, I have a job where they pay me, because I tend to piss off a lot of people when I talk.
All right. Excellent. So I think we're in questions and answers. Maya, I see you popping up. Does that sound good to you? And good, we have Denise back. Excellent. All right, so first question is a combination for Alex and Denise. And the question has to do with this vision for children's behavioral health. How could it, or does it, or do you imagine it might involve community health workers? And Alex, I'll start with you.
Well, first, states have to very specifically directly add CHWs as eligible providers in their state plan, and then ensure they are reimbursed at family sustaining wages, and make their credentialing and paneling reasonable and appropriate for the organizations that employ them. So that was sort of a mechanical response to your
Right.
question. What would it take to?
No, I kind of mean that, you know, you have this vision of really rethinking children's mental health access.
Yeah.
In of those different places that you talked about, do community health workers have a role, and if so, where do you see that?
Yeah, one way I try to describe this is go back to Dr. Thomas Bodenheimer's work in the early 90s, who was really one of the founders of team-based primary care. And there is I believe in therapy, it works, I'm trained in that way, but of the probably $1 billion I built in Medicaid, it was only appropriate for maybe 10 or 15% of the families I served. The vast majority of families need access to connection and partnership, some of the stuff that Doug was saying, and can solve their own problems if given support and social capital. So CHWs can play a critical role as clinical extenders, but maybe just as important as social capital builders. So we see CHWs as essential providers in a behavioral health team, hopefully concordant culturally, certainly more focused on building alliance than on diagnostic or other treatment modalities.
Got it. So this question then over to you, Denise, which is, you have a family that is struggling, in different ways, and the children are experiencing all kinds of challenges, maybe anxiety, depression. How do you see the role of community health workers? And then more generally at the policy level, do you see interest in this kind of model that Alex is talking about, where community health workers are really an integral part of a behavioral health team?
Yeah, thanks for the question. So the first thing I would say is when people are developing partnerships with authentic community health workers, we didn't spend a lot of time on that, but we are seeing folks who are just sort of hiring anybody who wants that job, people who don't have cultural alignment, deep experience, relationships with the individuals and families that folks are trying to make connections with. But when you do hire authentic community health workers, what you're saying is that I have walked this walk. So we have to really take that in to understand that that means I've experienced homelessness. That means I'm a person living with HIV. That means I am formally incarcerated. That means I'm a person in recovery. That is what allows community health workers, not in terms of the way that many people hire us, but that's what allows us to develop these relationships to facilitate the sort of readiness, the support, the comfort, the access to services that are currently siloed and sectored. So number one, you have to hire authentic CHWs. Number two, I would advocate that you don't bring them into many health systems. I don't think it is the model to take CHWs out of community and hire them and put them under sort of the purview and supervision of doctors or specialists and expect that what you're going to have is sort of a culturally aligned practice that is familiar and accessible to community members. Number three, we don't really have a vision for this workforce nationally, but let me just say this. It is not the case, and maybe folks think that it is not the case that any CHW can have conversation with a pregnant mom about Medicaid. Okay, whether or not she's eligible for Medicaid and supporting enrollment into Medicaid or any other service. That's a function of the way that we silo. And we know that during the early months of 2020, up to 5 million people who lost their jobs who were eligible for Medicaid didn't know it and didn't enroll. And so that translates to the mother who is pregnant, who's in a preconceptual state and needs care, or an interconceptual state, but it also relates to her children, because we know based on Alex's data that 10 to 24 age window, when parents are not accessing their services through Medicaid, children often don't access their services either. So we have many instances where we can connect people to mental health services, where we can be culturally aligned and deliver those services deep in community, and where we can leverage the lived experience of the workforce, right, to address the barriers and the solutions to mental health, but we don't do it with CHWs. So we have lots of places where we can make that connective tissue.
Great, thank you so much. Okay, next question is for Bonnie, which has to do with the workforce. And there certainly are innovative models of care that can support, for example, people to age in place. But the workforce for helping people stay at home is quite threadbare, and particularly these days. What do you see as the major opportunities to change that? How should policymakers be thinking about what can be done?
Great question. And I am just going to hop on the lived experience train. One of the things that's really great about long-term services and supports is we kicked the medical model to the door about 20 years ago, but we haven't figured out how to integrate care, I think, more holistically. And one of the solutions that we have our eye on is how do we look at people with disabilities as key contributors to people that we are hiring to support people with disabilities. So for example, you might take a person with an intellectual and developmental disability who needs some verbal prompting to complete tasks, and pair them with somebody who has a physical disability to provide that support. You provide gainful, meaningful employment for somebody while also pairing that person with somebody else who has a disability. And so there's an opportunity and community there. I also think that we have to look at the choices that we make people make. And so looking at this particular workforce, these folks traditionally make at or near minimum wage to provide really complex care that can be emotionally taxing. And so we have to look at what is a livable wage for these workers. And then we have to help them see, like, what are the career opportunities? Why is this a really good for, maybe while you're working on a degree, for you to get into this industry? What are the long-term possibilities? And it's not just being a nurse or being a doctor. I myself was a direct care professional for 5 years, right? So you might go into public policy, you might go into nonprofit, you might do a variety of different things. So mapping out free and tangible career latticing in terms of the medium and longer term solutions is what we have our eye on in terms of this workforce. But again, I just have to highlight, we have to go back to, as a nation, we have to value people with disabilities. We have to value older adults. And unless and until we do that, all of our workforce strategies will sort of be for naught, right? We need people to want to enter this industry because they see how important these people are to the fabric of our community more broadly.
Great. I want to kind of transition, as we are going to sort of the last section here, a little bit more to the policy levers that can achieve what you all have been talking about so compellingly. That not just policy levers for reimbursement for things, but I think you've also all talked about the redesign of systems of care. And so, there are some short-term funding, but as we try to follow the vision of using that as an opportunity to restructure things for the longer term, what should states or the federal government be doing to support the policies that allow for this transition to happen in care? I wonder, Doug, maybe I'd start with you. Is there something that Alaska has done, for example, that has made it possible for your health system to do things fundamentally differently, or at least, the examples that you've given? What are the policies that underlie that?
Yeah, money gets in the way all the time. And I think Alex in particularly, but others have spoken to this. And so, we're just dumb. We tell all our staff to do the right thing and not worry about the money. And then a few of us at very high levels lose sleep day and night on money concerns. And so we are, in our environment, we are actually predominantly fee-for-service. Medicaid, Medicare, private insurance is all fee-for-service for us. And the money we get through Indian Health Service and community health centers, FQHCs, all that stuff is a minority of our money, but that's our more flexible money. But what we do is global thinking, global planning, global budgeting. So no individual work unit is expected to hit a particular financial target or any of that. So whole system thinking, whole system planning, redistribution of money in whatever way we think makes the most sense. And the critical thing to understand in healthcare is it's so flush. Healthcare is so flush with overuse and overexpenditure that if you rethink your delivery system, you can find all kinds of money within whatever your budgets currently are, as long as you have a comprehensive enough budget. And one of the problems that's been brought up is that if your money comes in, like if you just run a community health worker program, then you can't pull money from anywhere else, and that's a problem. So part of what we do is we don't have, like, none of our work units, none of our clinics, none of our residential treatment facilities, none of our home visiting workers, none of our community health workers are on a particular, you must hit this target, and none of them have to hit a certain revenue to justify their existence. That's all done at a global level. In our system, we are pretty sure, using our math, that we give up about 30% of the money we could be making, which is tens of millions per year, but we've reduced costs by about 40%. And as long as you drive down cost more rapidly than you give up revenue, your margin actually improves. So we're actually very financially successful, but only because we removed just a ton of waste, not because we're in some preferential financial environment. Alaska has essentially no managed care. Even Medicaid is not on a managed care platform in Alaska. So we have to do it within a more fee-for-service environment, but whole system thinking.
Thank you. Denise or Alex, is there any thing you want to add to this question about, fundamental policy shifts that you'd like to see? Denise?
Yeah, certainly. So, when I logged on, and it was a few minutes late, Mr. Blum was sort of wrapping up some of his comments. And I just want to refer back to some of what he said, because I think it's important here. He talked about CMS not being too prescriptive in terms of defining roles for certain workers, but sort of being open to, sort of an expanded view of these workers. It was all, sort of a little vague for the federal government. And I think that's not what states need. I do think that we need to gather states together. We've been trying to do this in the way that we can with our small capacity, but also to push CMS to really articulate whether or not we want a significant role for a community-based CHW and for community-based organizations, and what those models look like. We talk about shifting accountability, and what that means is contracting, that means data sharing, and it also means dollars, but we don't have a good way to do that, and we haven't done that well during this pandemic. So I think that's really essential.
So a real national plan. Oh, sorry.
Sorry.
I was just sort of summing up a little bit, just to make sure I understand, but really a national strategy for community health workers with very specific,
yeah, that doesn't exist.
Right, and with very specific ways that states can change their policies to encourage their full engagement.
Yeah, and those are already evident and emanating from the workforce themselves. It's just that the workforce doesn't have a voice in developing policy. I think that California is doing some very exciting things in trying to center the voice of the workforce. But what we're seeing is that good policy, sort of just passing policy doesn't mean that it's good policy. We're seeing policies in states that are actually prohibiting certification or training. They're having all sorts of barriers based on language, the cost of a certification exam, a past criminal record. All of these things and more are preventing the very folks that we say we want to come into the workforce, to create a more diverse and culturally aligned pipeline with lived experience. We're preventing many of those people from entering the workforce. So not only do we have sort of an over-medicalized system, but we have a lot of professional bias. And so we have to change a lot of the way that we do that. And states also need support in developing legislation that's not just good in terms of ROI or its potential to generate funding or develop a workforce, but also equitable.
Got it. So yeah, we're talking about actual workforce policies in addition to programmatic and financing policies. Alex, you did talk about a number of state policies in your presentation, particularly on the delivery side. What else has to go with that to really accomplish this transition?
Well, I'll highlight two. One I said, which is I think the federal government needs to do FMAP change for kids' mental health. It's a legitimate crisis. Our kids are killing themselves. Like, yo, put your politics aside. Let's do something at scale. Secondarily, though, and it was named by CMS Administrator Blum, and I'm very much with Denise here, I think bureaucrats almost go to this term attribution as the challenge, like who to pay, who's responsible. And so what I would suggest is that we should create a new entity that is a delegated subcap entity under managed care plans. So this doesn't apply to Doug's amazing work. So Doug, keep doing it. But for those of us who are living under the reality of managed care organizations should be required to set aside a subcap for some kind of entity that directly invests in the lived experience, that has as its measure that some percentage of those dollars, to me, should be 80%, actually lands directly in the hands of people on beneficiaries. So force a direct pass-through from capitation into the direct experience and lives of beneficiaries. And I say this in part because a lot of Medicaid beneficiaries who don't even know the name of their health plan, like who don't feel trust and alliance with the systems that are meant to serve them. So we should directly privilege beneficiaries in the systems that serve them. And one way to do that would be to create a delegated relationship under all MCOs to directly privilege and invest in beneficiaries.
With 80%, you said, of the capitated?
I mean, this is Alex math, so everyone, buckle your seatbelts, but I would love to see some kind of subcap relationship. Like if we accept, particularly in my world, that kids who are 42% of enrollees, but only 14% of all expenditures, all of us who've worked around health plans know that you focus on the high cost adult consumer. Like that's where your bread is buttered. So kids will never be a cost driver enough to generate the type of change and shift that we need to see. So what I would love to see is some kind of accountable community for health, or a health and wellness sub-entity to a health plan, where a health plan must pass through some percentage of their subcap to that entity, and that entity is owned by beneficiaries and directly privileges beneficiaries with some minimum percentage of those dollars.
Got it. Okay, very good. Bonnie, could you reflect on this, and also just if you could work in this policy question about paying family members to provide a long-term care, which I know is something I did quite a lot of in Maryland when I worked there, but what policies come to your mind besides those that you spoke about already?
Yeah, I think that's great. Colorado actually has one of the most generous policies in place that allows support of payment of family members. And by that, we treat family members no differently than we treat anybody else. And so really looking at how do we make sure that people are able to hire the people that they want to provide the care that they need as a key strategy in that. Now, you have to put some protections in place in terms of family members not necessarily advocating for themselves when the person really doesn't want them to provide the care, or for that to be the only source of the family income, if that's not what the person wants, right? So it really does, from a high level, creating some flexibility around having family members provide the care, I think is key. Concurrent to that, we have waived portions of the Nurse Practice Act. So, if you take somebody who has quadriplegia, who's had a catheter for the past 25 years, that person doesn't need an RN to take out the catheter and change it, right? They can direct a lay person to do that and to do that well. And so I also think concurrent to family members is looking at where do we have regulations in place that were developed 50 years ago when the only place that long-term care was provided was in a nursing facility or in a hospital. And so you had all these credentialed staff around you to provide and to delegate that care. So when we're looking at workforce, when we look at the community, right, where we over-medicalize the model, where it's unnecessary, where have we required families to show up free of charge, where that's unnecessary, has to be a key component of how we close those gaps in care and really build a robust workforce.
Fantastic. Well, I want to thank you all for such a terrific discussion. I certainly took that this is a moment of a lot of excitement and hopefully transition within the healthcare system. And the openness to change that we heard from Jonathan Blum, now meets the opportunities for change that you all have spoken about so compellingly. And I really do think, in my mind, they fell into these three categories of not just the funding, that's one, not just the models that you talked about, but also the rethinking some of the human resources rules and regulations that could make all these things possible and really transform the workforce for a healthier and more equitable country. So please, I hope everybody who's listening can join me in somehow. There's some electronic way to thank these speakers. We should please do it. I can do something here for you. Hold on one second. Give me 1 second. I think I can do it. Here we go. This is my small attempt to thank you. But have a wonderful rest of the session, and back to you, Mai and Michael.
Thank you so much, Josh. Thank you, Bonnie and Doug and Alex and Denise. That was a really invigorating conversation with many, many wonderful and clearly practical ideas that you've already put live on the ground. I want to now shift to the second panel and invite Cheryl Powell to moderate. Cheryl is currently Senior Principal for Medicare and Medicaid Coverage and Payment and Equity at MITRE, and has over 2 decades of experience in Medicaid, Medicare, and private health insurance policy and operations. She has been, to me, a mentor and an incredibly inspirational operator. When she was at CMS in multiple leadership roles, she was the Deputy Director of the Medicare and Medicaid Coordination Office, lovingly known as the Duals Office, Technical Director of Medicaid Financing, and Director of Medicaid Benefits, Eligibility, and Managed Care. In all of these roles, Cheryl has always had this true north of person-driven care and aligning financial incentives to enhance value and outcomes. She has a degree in public policy from the Kennedy School of Government at Harvard and her bachelor's from the University of Virginia. If you haven't already perked up your ears listening for ways to leverage short-term funding opportunities as state decision makers, I would really encourage you to lean in, because this is a moderator who has written those rules and is now telling you how to take advantage of those rules. So with that, Cheryl, let me turn it over to you.
Thank you, Mai. Thank you for the kind introduction. I am so honored to be here and to be a part of this invigorating and critical discussion. And in this coming session, we do have a chance to hear about taking those evidence-based strategies that system leaders, that care and social services system leaders have implemented before and throughout the pandemic to enhance the technical and communicative capacity of the areas they serve in a manner that benefits health equity and strengthens the whole person and whole population health. It's about the person at the center of care and decidedly not over medicalizing. I love that term. And you're about to meet 3 people who are definitely on the campaign to prevent over medicalization of our care models. I would like to introduce our panel quickly. We have Cody Kinsey, who is the Chief Deputy Secretary for Health in North Carolina Department of Health and Human Services, and serves as their operations leader for COVID-19 and the pandemic response. With a lifelong focus on the mission to achieve health and wellness and an enduring commitment to equity. Mr. Kinsley stewards the work of 4 divisions, the Division of Public Health, the Division of Mental Health, Developmental Disabilities, and Substance Use Services, the Division of Health Service Regulation, and the Division of State-Operated Healthcare Facilities. Prior to returning to North Carolina, he served as presidentially appointed Assistant Secretary for Management for the United States Department of Treasury. And I would also like to welcome from Louisiana, Shavonna Howard, the Assistant Secretary at the Louisiana Department of Children and Families. She has spent over 21 years working in public service, beginning her career with the Catholic Community Services and Commission on African American Affairs in the state of Washington. She served as an enlisted petty officer in the United States Navy before transitioning to Washington's Department of Social and Health Services, with positions ranging from financial staff to social worker and overseeing the SNAP program and working within the workforce development program. And our final panelist is Camille Dobson, who is the Deputy Executive Director at Advancing States. In that role, she provides executive leadership, policy guidance, and intensive technical assistance to state aging and disability agencies she focuses on managing long-term services and supports as well as quality. And prior to joining Advancing States, Camille worked for 10 years at the Centers for Medicare and Medicaid Services, focusing on Medicaid policy and serving as a senior policy advisor in Medicaid managed care. Advancing States has also taken a large role in helping support states thinking creatively and innovatively and in a forward way in funding provided to enhance home and community services and the infrastructure to support those services during the pandemic. This panel, I think, is going to be as exciting as as lively as the last. I am very much looking forward to it. And I know that everyone here, and the panel included, we know that states are often where the translation of the vision of a whole person care hits the road and becomes reality. And you will be hearing 3 perspectives on this in our panel. And using sort of that operational framework of whole person care models, states are often at the forefront of innovation that incorporates the dedicated financing and innovative payment systems and methodologies to improve health outcomes and well-being. And states deliberately focus on, and hopefully we will be transitioning this to a much larger focus by all on the issues of care that is person-driven, inclusive, effective, sustainable, efficient, coordinated, culturally competent, and scalable. Exemplars really lie in social services and supports being provided to individuals and meeting them where their needs are based on their preferences and their goals in a way that really resonates. And in order to do that, the states are using consistent, sustainable, and certain financing aligned and integrated with payment methodologies, often across programs, to meet the same goals. And we find that this is truly an exemplar when it comes to care and tackling issues of care and social services and supports in the home, focused on the well-being of individuals and the populations served. And so we're going to turn to learning a bit about these programs. Have been fantastic long before COVID. And then we have states who I'm in awe of the ability that the states have had to really meet the needs as COVID, as the pandemic has struck. And now we're going to hear a few perspectives from the states and others who are really forward-looking and thinking about how do we take some pandemic funding, how do we take this crisis as an opportunity to drive change and innovation in our healthcare system? And how do we use that available financing to build for a better tomorrow? States have truly been able to capitalize on the additional pandemic funding, and along with being creative and using the statutory and regulatory flexibilities that came within the public health emergency as that opportunity for sustainable change. And those changes are making care, supports, and services focused fully on whole person health and well-being. And now we're going to hear the exciting work that's been ongoing within the states. I am first going to turn to Cody to talk about the work in North Carolina surrounding the social service integration.
Right. Thank you so much, Cheryl, and it's a pleasure to be with everyone today. Cheryl said it very politely when she said, take a crisis and make an opportunity out of it. She knows I just say crisis-tunity, and I think that that's a unique moment right now as we begin to both take what we've learned in the course of the pandemic to really throttle the work we were doing before the pandemic and some of this funding to try to drive us forward. So the story that I would like to share today is a bit about North Carolina's journey on this roadmap of social determinants of health. So on the next slide, you'll see the way that we have sort of integrated across an array of strategies for every North Carolinian, all 10 million of us, to have the opportunity for health. And this is bigger than our Medicaid managed care transition. This is bigger than a lot of other pieces, but it really underlies a few key drivers that were in place before we started the pandemic, as we've been working on this effort for several years. A hotspot map, understanding where disease and lack of access of certain resources are in a diverse population, consistent screening questions across that population whenever they enter care or whenever they enter partnerships with a community-based organization and trying to identify resources, technology platform that we'll talk about that really undergirds all of it to try to drive through. I mean, like many of you probably remember, the best that many organizations can do is handing out pamphlets and trying to help people do follow-up, but to really automate that experience, to supercharge that interconnection in our Medicaid program where we have some reliable funding. But I appreciate what was said in the earlier panel about being intentional about not over-medicalizing this work. And then one of the things we've learned in the course of the pandemic is leveraging community health workers as part of that on-the-ground interconnectivity to connect folks to resources. So all these pieces fit together in kind of the vision of where we were headed, and I'll talk about them a bit more as I move on to the next slide. So I mentioned already that specifically diving into the Medicaid managed care piece, we have structured in our transition to managed care for our Medicaid population an array of drivers that we think help us stay focused on 4 key priority domains: housing, food, transportation, interpersonal violence. And so those are, as you see, wrapped around care management, a quality strategy that rewards and buys health that aligns with this, value added in lieu of services. All of the things that folks know are kind of key to potential and innovative Medicaid managed care strategy. Want to zoom in a little bit further, you'll see specific focus on healthy opportunity pilots. Now, the healthy opportunity concept is beyond Medicaid and really access, and we've gotten private payers to use these screening questions, to really move beyond payer and be agnostic to that. But we've been able to put particular resources around the strategy with pilots in the Medicaid program. So on the next slide, you'll see where we start to sketch that out a little bit more. So we had, going into just before the pandemic, getting to the process of awarding these pilots and having these pilots throughout the state. So CMS had authorized up to $650 million for us to use this, where we could actually use those dollars coming up for a fee schedule for mattresses and temporary housing support and other things that we were doing. And the strategy of leveraging our Medicaid managed care plan to actually then help fund those services that were built onto the central platform. I'm getting the warning of time, so I'm going to move quickly here. I'm sure we'll save time for questions. For those of you that know, I turned my clock off, so I wouldn't worry about the time. But then tying into our human service organizations to actually then provide those services so that people get funded. We'll go ahead and skip to the next slide here. This kind of outlines, the big things that we've gotten funding for, and an example of some of the programming that we're able to use these Medicaid dollars for, in walking up to that line of being able to support this work. Go on to the next slide. I want to spend more time at the end. So the NC Care 360 is the technology platform that really undergirds all of this. You'll hear about Unite Us platform in many other spaces. I think it's been core to us as well, and being able to connect folks in a trusted environment and getting it actually integrated into EHRs so that whether you're a community-based organization or you're a physician or any other sort of healthcare provider, you're able to connect folks to services that now, if you're in a pilot region, are actually going to be paid for. But if you're not in a pilot region, or at least just getting connected to those services. The next slide, which I think is my last one, or second to last one, starts to say this is the crisis-opportunity. So as we came into COVID, all the work I just talked about was underway, and we really tested it out in the context of COVID. We were able to set up isolation supports in the context of COVID, and identifying folks that, essentially no matter how they came into us, see on the left side of the slide, a no wrong door approach of they tested positive for COVID-19, or they're getting connected by contact tracing, or they're a high risk individual, pulling them in through a community health worker program present in 52 counties to give them support services like the ones we were just talking about in our Healthy Opportunity Pilot, and then getting them connected through that program to any other services that they may need to provide the support to be isolated, to try to help, stop the spread of the disease, and to help keep folks safe in the context of COVID with all the other disruptions that we saw. That worked in plan with, we have 100 counties in North Carolina. In 29 counties, we're able to do a pilot. We picked those counties based off high social vulnerability indices. And you'll see at the bottom, we really braided funding across CARES, state Medicaid dollars, and FEMA reimbursement to make this possible. We also provided a statewide non-congregate sheltering program that made that supportive isolation even more possible. And the last slide, I'll just highlight that, key lessons learned from this effort was that first and foremost, I think we were lucky that we were down the path of building out the capacity and the framework and this Healthy Opportunities. The fact that we could leverage the Unite Us or the NC Care 360 platform in advance of this to have folks connected to services for supportive isolation was really critical. I think a learning space for us was how important the connectivity with our community-based organizations is. The relationships that they have not only to provide services to community members, but to get them connected and frankly to leverage those connections pre-existing to get folks connected to care or now later vaccines. And we saw some really interesting results you'll see highlighted at the bottom here, which is, we saw consistently in those counties where we were doing this work, a 12 to 15% decrease in positivity rates because we were able to support folks in isolation. We're also particularly proud that these supportive services, over 70% of them were delivered to historically marginalized populations. So I think that this really put to test our concept of how do we leverage resources, connect them appropriately to people, and give folks the opportunity to be healthy. And I think in this case of COVID, some early results that are quite promising. So much more we could talk about, happy to answer questions, but excited for this conversation. Back to you, Cheryl.
Thank you so much. It's such exciting work, and we'll transition now to Shavana Howard and her work in Louisiana, focused on food insecurity and also connecting, sort of being these programs are the connective tissue, I think, across so many programs and in support of so many issues for individuals. Shavana?
Thank you, Cheryl. And what you said is just so true. I mean, we all work with and help to uplift individuals who are in poverty. And our team has focused greatly over the last year on how do we make an impact on this thing we call poverty. Next slide. You'll see, and I put this here, we often talk about our work, and I often say that we are an anti-poverty department. What we are doing is trying to uplift people out of poverty. And there are so many opportunities, as you can see from these statistics here, that we have in Louisiana to do just that. Unfortunately, this is data from 2018 and 2019, but Louisiana has ranked highest in poverty and child poverty, income inequality for several years. And we have been doing some intentional work, especially with the funds that we received from the pandemic, to help shift and change the mindset of the people in Louisiana to see this as opportunities that we have for real improvement and growth in a lot of the programs that we are able to deliver. Next slide. One of the things that we've worked on a lot, especially with the pandemic, is we definitely saw an increase in our caseload. Our caseload quadrupled, within a month's time when the pandemic first hit. And so what we were really trying to identify is, we often serve individuals who are either in situational poverty or who are in that generational poverty. And what we were realizing, because of the high level of poverty we have in Louisiana, is are we reaching all of the right individuals? The federal government provides us with funding under SNAP in order to do outreach services to ensure that people are getting their basic needs met, that they're able to eat. And so we partnered with Urban Footprint to do some work to really ensure that we are targeting the right populations. They're able to provide us with current data through census, through UI data, various other data streams that they use in order to close the SNAP gap is what we're calling it. Intentionally making sure that we're reaching the right households, that we're not ignoring those marginalized populations of individuals who are in that generational poverty, who really need to just have their basic needs met. This tool that they've been able to build, which is really like a map you'll see a little bit later, really allows us to do intentional outreach with our partners to make sure we're reaching the right communities of individuals who are truly food insecure. We also realize, next slide, that there is a large population of individuals who have been food insecure for some time. Congress has been working on trying to address and identify this, but it's really ensuring that college students have access to health and to food. We know that there are federal regulations that are in place that have made it hard for individuals who choose to go to school to actually be able to have their basic needs met. There's this assumption that you're going to be able to go to school and that you're also going to be able to work full-time to take care of yourselves, and or that you have a family who is actually going to be able to support you while you're in school. But what we know is for the individuals that we serve, so many of them have been in poverty for so long, that deep-rooted generational poverty, that there really is no other assistance that they can have. So what federal flexibilities are currently available? What additional flexibilities can we request from Congress so that we can address the food insecurity that college students experience on campuses? The federal government we were fortunate enough through the CARES Act to get some flexibilities on who is eligible as a student to be on the SNAP program. And we are working to not only ensure that the college students and or the college campuses are aware of these programs and these increased flexibilities, but also working very closely with them to identify what tools do you need to ensure that you can support the students so that they can apply for and receive these services that they're actually eligible for. Next slide really just shows the populations of students that we're serving here in our state, and how so many of them, all of them, once the understanding of what is available, what they are entitled to, because of being food insecure and living in poverty, and the wages that they don't have and their families may not have, how can we connect to all of these populations? We're using the Urban Footprint tool to help us to make that connection, but also just using our partnerships with the college systems, whether that's the universities and or the community colleges, to ensure that awareness is there for all of those students who could be eligible. Next slide. And interesting, Cody mentioned this earlier in his presentation, but we have been working, we continue to work with trying to provide a no wrong door approach. And we are doing that through the Unite Us 211 platform. So a lot of our contracts, like our TANF initiatives that we have, we are requiring that they accept referrals from the department using this tool so that we can track the services that individuals are actually being able to get referred to, and also that to see if they're actually receiving the services that they've been referred for. Oftentimes, especially during the pandemic, recessions, there's a lot of funding that comes to the state government, and because of the way that the funding is allocated throughout the state, oftentimes we can see ourselves kind of doing some of the same work when we can work better together. So how do we braid these things together? So the Unite Us platform has helped to really do that for us. It's really allowing us to see what do we have available to us throughout the state, and what's the best way that we can use these services. Oh, I'm going, Cheryl. Okay, next slide. I'm gonna go through these slides very quickly, but we've just done a review of our child support system, the entire system, by an outside agency to move us away from a penalized organization to more of a family-centered child supportive services. We know that children thrive when whole families are able to support them. So how do we help to build up the whole family? How do we help to connect the non-custodial parent to employment, to identify the barriers for the services and supports that they need, that we have within our reach, that we can make sure that they have available to them to make it a better experience for the child and for the whole family. I'm gonna have you skip through the next 3 slides so I can make it to the other 2. If you could go to 2 more, 1 more. There we go. One of the things that we've done, as you know, in the state of Louisiana, we are nothing but resilient when it comes to storms and disasters. The pandemic definitely brought great opportunities to us to actually test a virtual DSNAP environment. So rather than having 300,000 people coming into a stadium, if you would, the Pelican Stadium, but there's so many arenas here that usually would be filled with people applying for SNAP benefits to help because they've lost everything. We implemented a virtual process that we used a call center platform. We invested some of our pandemic funds to do this work. And we were able to serve the same individuals without them having to go anywhere so that they can remain safe from the COVID pandemic. Our numbers are so high in our state. We were looking for how can we do this in a way that keeps people safe, keeps our numbers down as far as our COVID numbers, but still gets people the basic needs that they have, or be able to meet people's basic needs. In 2020 and 2021, those two slides pretty much just show that we operated 6 DSNAP events. The largest, which just recently happened in Ida, in which we served over 300,000 individuals because it hit the highest populous areas of our state, excuse me. And through this virtual model, we were actually able to lean on other states to support us. So we actually received help from the state of Texas, who donated hundreds of their staff, the state of Oklahoma, who contributed hundreds of their staff to help support lift Louisianians up who've been impacted by the disaster. The next slide. And we have been spending the last several months on trying to identify systems that make it easier for individuals to access our services and make it easier for staff to provide those services. So we are looking to build things like benefit estimators, if you would, on you would be eligible for SNAP and or DSNAP if you meet these different criteria. It allows you to put in your information to see, do I take the time to wait on the phone for 30 minutes to apply for SNAP and or DSNAP services, or do I not? So these tools will be available during our next event, but we'll also be using these tools and have similar tools available for all the programs that we provide within the department. Another tool that we're working on is a benefit verification system. As we talk about often, there's so many organizations who receive these same funds, and so many of them can confer eligibility if somebody is on SNAP. So it's a matter of how do we give them access, limited access to our system to make it an easier client experience. And a benefit verification system would be technology driven, would allow you to log into a web-based system and really just enter in the client's information if they're applying for housing assistance, and they would have the client's information and approval on their side, but the system would tell them immediately, yes, they're on SNAP or no, they're not on SNAP, so that they can confer eligibility and make it an easier process for the clients so that they can access services. And then lastly, I talked a little bit about, next slide, the urban footprint contract that we have. This is just an example of the work that they can do. They are currently gathering data for us for the parishes throughout the state to talk about what does poverty look like in each one of these states and how are our programs truly impacting in these areas. Are we truly moving the needle when it comes to poverty? We're overlaying this information with all of the data that they currently provide, but then with aggregate level data on our programs. So looking at what does poverty look like? What are the programs and resources that we're providing? And then where's the gap where we need to do better work? The tool has been a huge success, and it's going to be something that we use not only for food insecurity, but also for poverty work, for connecting with non-custodial parents in the child support arena, and then also for connecting individuals and other agencies with employment and training programs. And all of this really happens from the collaboration and partnership of really talking among states of what are the federal dollars that has come into your state. Our governor does a great job at creating, at the sub-cabinet level, creating a platform and a space for all of the state agencies who are receiving these funds to share alike all of the things that we are working on to try to align as much as we can within the system to truly help move the needle when it comes to reducing poverty in our state and helping those individuals in need. There's so much work, and I'm going to stop there because I know there's going to be time for questions. The last slide I will show is just really where we are in the pandemic. You know, back in 2019, Louisiana supported, at least within DCFS, 1 in 5 families. And because of the pandemic and the state being hit the way that it is, we are now supporting 1 in 3. So how do we do a better job of truly lifting people out of poverty, providing employment and training services and a career pathway so that people can become self-sufficient and really focus on them and their families and reach their potential? Thank you so much, Cheryl. I'll hand it back over to you.
Thank you. I'm going to hand it back to you for 1 second because I'm going to admit, coming at this from more of a Medicaid background, I'm not fully versed in the difference between SNAP and DSNAP. And I was wondering if you if you can maybe talk about that a little bit more before we transition.
Of course. So SNAP is a federal program that's really intended for people who are in poverty, right? Whether it's generational poverty or situational poverty, but it's individuals who are typically at 200% of the federal poverty level or less. DSNAP is for individuals who are in that short-term situational poverty just from a disaster. So it looks at the income levels a little bit differently, right? So in SNAP, since you're looking at 200% of the FPL, for DSNAP, you can have a business. You know, you can own a home, you can own a vehicle, but lose everything. And because of that one situation, you now have nothing, right? No money to support your families. You don't have a job to go to. So it looks at your income, your resources all differently, and still provides a short-term food assistance benefit for you during the time of the event.
Oh, thank you. That's fantastic. I feel excited that I learned so much about just that and just that. Thank you. And with that, I want to transition to Camille, and I wanted to pull a little bit on a thread that Shavana was talking about and that Louisiana is doing, and that is capitalizing on the various federal funding coming in. As we know, at times when they come into different parts of the state or different programs, we don't always optimize the use, or they may end up being siloed slightly. And ways, Camille, that you may be seeing in your role at Advancing States. And I think one of the things with the home and community based services support that states are seeing that are coming in through the pandemic support is the focus on transcending some of those artificial lines between programs and seeing alignment with other supports and services programs and social programs. So I will ask for that, as well as what you may be seeing in the lines of innovation and creativity as states are focusing on how do we take this investment and transform care. So with that, I turn it to you, Camille.
Thank you, Cheryl. Good afternoon. Excited to bring my area of expertise and passion to the group today, focused on long-term services and supports. For those of you that aren't, since Bonnie spoke already, I feel confident that you are aware of the fact that LTSS, those non-medical services that help people live an everyday life, are generally only covered by Medicaid or out of pocket. Medicaid is by far the largest funder of those services, to the tune of about $235 billion a year. That means it's state and federal funded. Historically, the long-term services supports have been provided in nursing homes. And that's what most people think of, long-term nursing home services. Over the years, the system has evolved very effectively to a more balanced system where individuals are getting services in their own homes. But for older adults and people with physical disabilities, which are the sort of focus group that our members are working with, that's not really the case. Across the country, between 40 and 42% of older adults are in the community, which means the majority are still living in nursing homes. And so the home and community-based services system is still woefully underfunded. And the American Rescue Plan provided an amazing opportunity for states to transform and really grow that system to serve individuals where they want to be served, which is in fact in their homes. So back to person-driven, person-centered planning. Polls have consistently said that individuals with disabilities, older adults, people with IDD, all want to live at home, whatever home is for them. The ARPA, what we call affectionately ARPA, provided scored at about $12 billion in additional funding to the states for them to invest in strengthening and expanding their home and community-based services infrastructure. The great thing about that $12 billion is by the time you add state funding to it, and the additional services that can be claimed for federal match, we actually estimate from the state spending plans an impact of about $35 billion. That's more than a 20% increase in funding for home and community-based services, which is the largest since the program started in 40 years ago. So it is a one-time transformational opportunity for states. In order to access the additional federal money, which is running through the Medicaid program, the traditional matching process, where states put up funds and then the federal government provides the matching funds for them. The states had to submit spending plans to CMS on what they were going to do with those funds. Our organization, as the membership association for the aging and disability agencies, has done an analysis of all 51 spending plans to really identify where states are investing their resources. For most of the states, the two top priorities. One is investing in the direct care workforce. So for people to live at home and get unskilled, non-skilled care, you need people. Technology does not get you out of bed. Technology does not make a meal. Technology does not bathe you, right? The basic things, they will not help you balance a checkbook. They will not help you manage your medication. That's not really true. There's technology to help you manage your medication, which is amazing. But be that as it may, it is a very time-intensive, resource-intensive work. And so states, and it is a crisis of massive proportions, that there are so many people that are going to need services in their home to stay in their home and not enough staff. So states, almost 40 states are investing money in provider workforce training initiatives, including career ladders for direct care workers, high school training programs to encourage individuals. Back to think what Bonnie said at the tail end of her session, her piece that she spoke about, that you need to make direct service work or hands-on work a valued activity. So there's sort of a big focus on the sort of soft resources that you need to make an HCBS program run. And then back to whole person health, a lot of investment in technology. The home and community-based services sector has been siloed for years out of the regular Medicaid program. They might be integrated for claims payment, but not for care management, certainly not for any kind of medical intervention. Most of the individuals that get HCBS are also Medicare eligible. So you've got the complexities of managing Medicare and Medicaid data. States have recognized that that's an inefficient system, creating silos, not leading to good health outcomes for our populations, older adults and people with physical disabilities. And so we're investing an awful lot in electronic health records for LTSS that are compatible with medical EHRs, information technology systems that allow different payers to communicate with each other, even not through an EHR, about those individuals, so that, for example, individuals with physical disabilities are much less likely to have preventive care services, because no one's really not paying attention to those services where it's primarily fee for service, and there is no accountable entity to manage. Those data sources that allow a care manager to know that an individual has not gotten those resources, those services, and prompt them to access the medical services, even though they're not responsible for it. Spending a lot of time on additional services, assistive technology. So in other words, looking at opportunities, one-time opportunities to invest these resources in a way that will build the foundation for a longer term, more sustainable system as we all age. We want services to be available for us. And at this point, the way the system's currently structured, it is not currently sustainable. So we're excited about the opportunity. And I think as the states are only about 6 months in to this, we'll have a lot more learnings about innovations that come out and can be replicated across the country. I'll stop there. Hopefully there are questions.
Oh, there are lots of questions, and they're great questions. So I can't wait to dive in. I'm gonna start with Shavana on this one. I'm warning you, you're getting this one first, and then I'll ask the other panelists to dive in. And this question comes from the audience. There are just so many states that are not prepared to innovate for one reason or another. There may be a lot of interest, but and political will in reducing cost, but the state, either the state of information and IT systems can't support these changes, or there's another obstacle or barrier to being able to really adopt these innovations. So the question from that is, what changes are possible in these states, and is more direction from the federal government needed? So this is pretty much a follow-on to my question when we spoke earlier of, how did you get everyone to buy into your crazy idea? So with that, I'll turn it to you so we can hear about that and have the other panelists react and add.
Thank you, Cheryl. And it's a great question. I'll tell you, I'm an inquisitive person who loves data, right? So oftentimes before I move any of my crazy ideas forward, I typically am able to connect them with, what does it mean to people, right? The people that we serve, and what does it mean to our state, right? So, with doing the virtual DSNAP, I will tell you, I remember sitting with the governor and, pitching this idea of doing this virtual DSNAP, and I've never done one at a large scale that they do in Louisiana. The idea that 350,000 people will sit in a stadium for 8 hours in a day in Louisiana in the heat with no fans. They brought in fans. I think they had porta potties. They did a whole lot of work, right? But the idea to do something like that during COVID just made no sense. I think everybody wanted to keep people safe, but it all starts with, how do you do this differently? I think the one reason that people are so hesitant is that they can't see the vision of what is it now and what could it be? So you really do have to bring people along that journey of what could it be. So I remember when I met with the governor, it was a matter of, this is what we have now, but this is the percentage of people that we can still serve. This is the amount of money that we could still save, in doing this model and still meet our basic principles. And so it really is about, providing people with the data, providing people with the anecdotal stories of the client lived experience, and using that lived experience to help shape and guide how we move things forward to the best of our ability. And there is some really understanding, what do the regulations require? Because I'll tell you, oftentimes, especially in a policy standpoint, people live in the black or white world when it comes to policy. And supervising policy staff for years now, they realize I live in the gray, right? There is gray in all policies and all programs. And to me, I think of that gray as the land of flexibility, right? That's the flexibility that the federal government provides to states in order to operate in a way that works in the best interest of our states and our citizens. And so trying to get people to shift their mindset to, it doesn't say you can't, but it doesn't say you can. And that truly is the gray, right? That's where you can live. And being able to show people where you're starting and where you can go, using data to get them there, being able to partner with agencies such as Urban Footprint to actually be able to say, this is the data that we have on poverty, right? This is the data that we have on eviction rates. This is the data that we have on COVID. We work a lot with, the Department of Health, the Department of Education, all of our partnering agencies, because all of us are truly providing services to the same people, right? It's the same individuals who are usually that are really in that generational poverty that are tapping into all of these services and all of these supports. So it's a matter of, how do you see and look at people as with value that you can invest in, knowing that they're truly going to make a difference, knowing that poor people don't want to be poor. People don't want to live in the lifestyle where they can't take care of themselves and their families. It's just hard, especially in generational poverty, to truly see things differently, to see that those options are available to you. And so if you can combine that lived experience from those in generational poverty, as well as situational poverty, because you learn a lot of different things from them also. Sometimes you get some of the best ideas because, unfortunately, people can connect more with situational poverty than they can with generational poverty. So they're more likely to put more dollars in these areas right? But you can use that as an opportunity to pilot a program, right? To show people on a smaller scale, this is what it could be, and then roll it out for the larger population, in years to come or months to come, which we were able to do here in Louisiana.
Fantastic. I believe the land of the gray is where the magic happens. So I'm going to ask Cody. Or it looks like Camille. Camille's off mute. I'm gonna
It's funny. I was actually struck by Shavana's first slide that said Louisiana's an anti-poverty, right? State, right? And the sad part of our long-term care system in this country is that it's a poverty program, right? The concept of lifting people out of poverty when they're young, right, or of childbearing age, and then when you have a disability or you're an older adult, you have to impoverish yourself to get the services that you need it continues to really blow my mind. And I think one of the things that we trumpet regularly, as much great work as our states do, and they do tremendous work, the fundamental flaw in our system is that long-term services and support is not recognized as a necessary set of services that individuals' retirement programs, for example, should include, that Medicare doesn't cover those benefits. We continue to be surprised. People get surprised that they're not available. I'm sorry, I'm just struck. I'm not even answering your question, but I was struck by your conversation around poverty and how different it is when you age or have a fundamental disability that doesn't allow you to work, and what the system looks like for those individuals. Sorry, Cheryl. You know I don't follow what I'm supposed to do.
I would be shocked, Camille. Camille lives in the land of the gray, and I would be shocked if you followed the rules. So no worries.
I just want to jump into the land of the gray and say that I couldn't agree more with what Shavana and Camille have said. And I think a key point here is that, we're constantly battling against what I call the wrong pocket problem with regard to government funding, right? Because part of the issue, sure, if I want to spend a lot of money on interpersonal safety, housing, employment, that's money. But if I save money by folks not ending up in services provided in the homeless system, in other support services, or tragically often, especially when we think about mental health, in the criminal justice system, the reality of that cost shifting is where I have had the most success in building a coalition of people across different spectrums and different approaches to this work that want to invest in this. Because, it's cliche to say, but it is so true, an ounce of prevention is worth a pound of cure. And this work, whether it's long-term services and supports or isolation supports or SNAP benefits, are pure and simple prevention when it comes to long-term, incredibly expensive health work. And the last thing I will say on this is that, I kind of jokingly say that social determinants of health have become a bit more sexy in the last several years, and people are talking about it because jokingly some ER doctor realized if they changed the carpet, they'd stop having kids come in and have asthma attacks. Like, oh my gosh, think of all the money we're going to save for the health system. Where it's like, for every person working in mental health knew they were never going to help someone's psychosis if they weren't not securely housed. And it is just plain and simple truth that we have to face those things. But unfortunately, I think that what's on the frontier for us in this opportunity where we're seeing this unprecedented amount of cash, we can see pilot opportunities to demonstrate DSNAP that if we thought about budgeting in the context of every dollar that goes to their prison system or every dollar that goes to these other things that could be more spent up front on people, we would transform the way that these systems work.
Excellent. No, I agree. I always think social determinants of health, and I think, well, states have been doing this forever, but now it has a new fancy term that people are globbing onto. So, so the next question. Oh, go ahead, Camille.
No, I said I couldn't agree more. The LTSS system, that's all we do is provide social determinants of health for people in their homes and communities. And the fact that the medical community has just sort of woken up to this in the last 4 or 5 years, that so much of what determines how people live is not in the doctor's office or in a hospital is, it's ironic. I usually smile when I hear somebody talk about social determinants of health, and I'm like, you need to talk to our area agencies on aging because they'll tell you about social determinants of health and what they have been doing for the last 45 years in that area.
Exactly. And so Cody, we have another question that came in, and it relates a little bit to what you had mentioned at the end, and it's about that. How has your state adjusted its collaborations? The question is specific to CBOs, to community-based organizations, but we talked earlier a bit more with those organizations, but also the healthcare infrastructure of those providers, and pulling them a little bit further into our world where SDOH lives and has been for a while. How have you adjusted your collaborations to enable the entities to deliver services during COVID? And then specific to the CBOs, and I think we've seen this in long-term services and supports too, is that struggle with staffing and capacity for that great need. And so looking for ideas for how it's been working well, where you've seen that, and then future planning with this challenge.
Yeah, no, great question. And I'll approach it from a few different directions. So first, with regard to community-based organizations, North Carolina state government, it didn't have a retail apparatus, right? And so facilitating that retail operation, we have areas on aging, we have other entities that have been referenced here as far as on the game work, but synergistically that stuff working together, especially in the community, in the kind of CBO space is different. NC Care 360, as we envisioned, that was our first foray into having direct connections with these providers in communities that are going to be doing the work that they do, the work on the ground all the time. I think that what we learned through COVID is how much we needed to learn about how they operate, what they do, what they drive. I mean, look, these organizations operate on razor-thin profit margins. Step one is paying people for the work they're doing, right? And I think that is something that COVID allowed us to do. Like, how often do we pull together a bunch of groups that serve historically marginalized populations? We say, we need you to do more for free, right? And so I think thing one was paying them to do the work and to leverage their trusted connection with people to get them plugged in. I think coming at this from the perspective of the healthcare providers is that nothing like a global pandemic to have everybody who thinks they don't need government run to you and say, oh my God, please help us. We don't know what to do. And I say that lovingly. We build a phenomenal relationship in the fire with so many of our healthcare providers, our big health systems, our doctors, because we've enrolled everybody in vaccine programming, and they knew that the work we were doing in support of isolation meant that they were going to have less folks show up in their EDs. And so I think what we got in the trade for that is, one, them putting their NC Care 360 into their system and putting it to use, and two, sharing with us unprecedented amounts of data and transparency about their behavioral health holds, about people coming into the ED, about their, 90-some variables every day that we were never getting, and visibility into what some would say was market sensitive. And so I think that allowed us to really create a transition. So I think that, plus, now the third point you mentioned about workforce, this is a serious issue, folks. I mean, I know this is the topic on the prior panel. I've, in the state-operated healthcare facilities that I run, I have a 30% vacancy in nurses alone. And we have a lot of folks, especially in the direct care support professional space, who are like, look, I can go work in any number of other jobs with significantly less risk, significantly more work-life balance, and significantly better pay. So I'm going to give up a profession of passion, and I'm going to go find some personal life balance. I think we're still all seeing what's going to happen there, and that's going to balance out a bit. I think the HCBS opportunity, and Cheryl, we've talked about this, Camille, you alluded to this, is an opportunity to do some investment there that is unprecedented, that I think we need to do. And it's not even about investing for the future, it's investing for the now. But I also think that it goes back to, frankly, just pure and simple, regarding these professionals as professionals that provide a health-oriented life-saving service, and the respect and dignity that they are due in that work. Because I think, unfortunately, whether it's home care nurse aides or other sorts of direct support professionals, for too long in our societies and our communities, that has been seen as a catch-all role, and that dates back to a long history, a lot of other problems that we could do a whole nother panel on. But I think that we've got to also think about, how do we stop just saying these people are heroes and actually treat them that way.
And Camille, do you want to talk a little bit about what you've seen in the home and community-based services world? I know there's been a lot of focus on shortages for other providers, in nursing facilities and things like that. I have been very worried about individuals who are in their homes, you know, the constraints during the pandemic for getting into the home and doing some of the services. And then how do you use the investment that's coming now to really build something that's sustainable with respect to workforce issues going into the future? And any innovations you've seen with particular states would be great too.
And I was going to follow up on what Cody said. The direct care workforce is really a health equity mission because so many this country are women of color, immigrants, and addressing their needs for a sustainable wage and sort of a career hits a number of target areas for states. I think that's an important thing. The emphasis on the direct care workforce does a number of things to drive their overall goals for their healthcare.
Thanks, Camille. And I hope that connection works better. If not, we're good, but I'll keep coming back to you and we'll see how it goes. I wanted to ask, and I'll start with Shavana, I think, for this one. You talked about that braiding of some of the funding and the coming together. And one of the questions that we had is really, what role does alignment and collaboration have at the local, state, and federal levels? And what does that play in ensuring that the interventions are scalable, equitable, and sustainable in advancing whole person and whole population health and care, you know, helping lift out of poverty and providing those services that promote health and well-being? And I always fear that we're at a great moment, but we're at a great moment that could either drive future better change, or we could step back from that and kind of go back to our siloed world. So any thoughts on that would be really helpful.
You know, this is definitely, I think, one of the best opportunities that we have to really do something that's impactful and that's going to be different. I think that, you know, we have a great opportunity, especially here at DCFS, just because we have so many different funding streams, so many different federal partners who understand the direction we're trying to move to, and realize that what we have realized all along, you know, giving people benefits is the first step, but it's not the end all that be all, right? What's really going to lift people out of poverty, what's really going to make long lasting change is to get people connected to employment. So we have done a lot of work of really refocusing on our work for building a workforce development section within our department, and also aligning and respecting the workforce development ecosystem as a whole, right? Recognizing that, you know, we have partners who live in this world, but the challenge that they have is seeing the resiliencies and the talent pool that we have because we serve people who are poor. So it's really connecting with the college systems, connecting, and we've done some great work with connecting with all of our federal partners from the TANF side of the house, the child support side of the house, and the SNAP side of the house. You know, one of the first things I really worked on was taking all of our employment and training programs and creating their own workforce development section, if you would. Because from a client perspective, it should be no different where they start on their career pathway. It's just that career pathway continues. Because we know that as soon as they fall through that crack, it's going to be really hard for us to pull them back up and get them re-engaged in services. And if we're truly talking about making a difference, we're going to have to make sure we're connecting people with meaningful employment that matters, right? And so we've had some great success working with our federal partners, really getting them at the table to see what is the direction we're going in, what are we trying to emphasize, how are we really trying to, you know, to battle this thing that we are calling poverty, especially the generational poverty, not the situational poverty that really doesn't need so much of our services and support, that maybe just need the benefits for right now because they have an education, you know, they have a degree, they have a career. But we've seen some great partnerships, and we recently just received $20 million from Office of Child Support Enforcement to create a child support employment and training program. So it's another continuum of services and care for individuals who start maybe on our TANF side of the house, but we know it doesn't take but just a couple of dollars for you to be no longer eligible for those programs. So it's that continuum of care for individuals along their career pathway so that they stay connected, so that they aren't reliant on public benefits And we don't see that churn that often a lot of our, safety net program sees, but truly making impactful difference for individuals. And then also just meeting people where they are. And Cody mentioned it earlier, and it's truly providing that no wrong door approach and getting the federal government to understand and align participation requirements, performance when it comes to work participation, whether it's on the Medicaid side of the house, the SNAP side of the house, regardless. If they control all the pockets, if you will, right? If they can just align all of the work performance standards, work requirement measures, it'll be so much easier for not just us, but states who do a lot of partnerships with local community-based organizations like we are starting to do here in Louisiana. But for them to be able to provide these services in their local communities, that's truly going to make a difference. And not only with employment and training, but also with addressing other health needs that individuals have when it comes to medical or housing or childcare. I mean, I can only imagine being a nonprofit organization who truly is taking funding from all of these different buckets and having to check the box. I tell my team all the time, I'm tired of being box checkers, right? We want to be able to make impactful change, and checking a box does not move people out of poverty. Checking a box keeps people in poverty and keeps all this red tape and this silo chaos that I consider just so unnecessary and really trying to move people forward and make some true innovative and progressive practices.
Yeah, I just agree. I would want to chime in to say, I think underscoring, especially in this frame of how are we investing for the future with these resources that we're getting, but investing in data systems that help us understand how all these programs wrap around people, as opposed to how we wrap people around all these programs on the list of checkboxes, I think is another critical point, and it loops back to this issue of how do we sell the value proposition here, which is if we can understand the outcomes as far as getting people out of intergenerational poverty because we wrap benefits in a certain way, then we can replicate that. Right now, there isn't a lot of measurement happening across these silos, and I think that's critical. The other thing, just on employment, it's everything. And I think this is one area why we have been so focused on peers, because it's a double win. It's an opportunity to give individuals lived experience from a variety of different walks of life, an opportunity to be a peer support navigator or whatever that is, family peer, for individuals, and I think that's an opportunity to continue, and also goes back to something I should have said with regard to the workforce issues.
Great, and I have a very aligned question to follow up from the audience, and that is how do we go about measuring success and outcomes, particularly when you're thinking about doing that reliably, in a way that reliably keeps track of individual patients' trajectories across multiple providers, especially when you're pulling in non-traditional, non-clinical providers, such as the community health workers. And is a personal health record system needed that better integrates? And I know Camille had talked a little bit about some of the long-term services and supports, the state's building some bridges into the healthcare records as well. But so we'll get to Camille if she's able, but I'll start with you, Code. Oh, go ahead, Camille.
Yeah, no, I'm here. I think that's a great question. I hopefully Shavana and Cody as state leaders will sort of acknowledge the fact that or recognize, I think, that states have long wanted to do and not stop to think about evaluate. And I think that's been a challenge in general. This and our technical assistance to the states as they're thinking about their spending plans is very clearly just to have a benchmark to start with, so that they can actually show the value of the investment over time, right? To prove that in fact they've made a difference. That's at a system level, though. That doesn't quite get at, I think, what the individual is asking about. And from the LTSS system perspective, it's long been a problem that they have been isolated and siloed from what's going on in the medical system. The development of LTSS EHRs for sure is helpful. It's a lot easier when you have an integrated delivery system, for example, like they have in a number of states where a healthcare provider is sort of the lead and is in charge of the population health and has a system. I think the development of state HIEs is a great opportunity. Those are a wonderful tool for sharing information. But again, our states, many of them have found that HCBS providers in particular don't have the funding or the resources to be able to access the HIE. So providing, for example, one-time grants to get CBOs and small providers access to an HIE so they're able to see, for example, discharges or admits so that they know when somebody needs services. And then the last I would say is asking people, just asking people. It's the core of being person-centered, is to ask people how they're receiving services, not just their medical services. Because I think if you're in a health plan, which most individuals in the United States who are on Medicaid are in a health plan, and they get asked regularly about their medical services, they don't really get asked about their whole life and how those services affect their whole life. And so we encourage states to think about ways to assess the quality of individuals' lives and the services that they get.
I definitely agree, Camille. And you know, it made me immediately think to, you know, for so much of the programs that we have and, you know, the social and health services, as far as the cash assistance and the food assistance programs, you know, they often come especially with some requirements to engage in some type of activities in order to maintain those benefits. But who are we to determine what is the best roadmap for a client, right? To lead them to self-sufficiency? How are we going to judge what their roadmap needs to look like? It truly goes back to recognizing that everyone is different. And it's a matter of not looking at people as a widget in a gidgeter, if you will, that you have to put them in this square hole, but realizing, meeting people where they are. You know, how many barriers are you coming to the table with, right? Whether it's food related, whether it's housing, whether it's medical and or mental health issues, but how many barriers do you have? And how many things can we help you to overcome, right? By solving those things and looking at it from a person-centered approach, identifying and meeting them where they're at and helping them to overcome and remove those barriers, they're going to be better off in a year. They're not going to need our services. But trying to fit them into a box that does not fit, that does not take into their culture, their background, their lived experiences, we're never going to make a difference of actually helping truly to lift people out of poverty and make impactful change that's going to truly not only help them to do better, but to empower people who haven't had the power for so long that they can do better, and we can help them to get there.
Yeah, I think we have to go after this from both sides. We have to go after this in the how do we think about the infrastructure that gets the data wrapped around people. And I think HIE is a great platform, and that's, you know, frankly, HIEs have needed a jolt to move forward in many states. And so I think we've had some progress there, and I think that's a good opportunity. I also think looking back, we've had some natural experiments through COVID, I think DSNAP in particular, but others where presumptive eligibility and some other things that have frankly just carte blanche removed some boxes, give us some real world data about the positive impact of that. And I think that we need to go after kind of silo by silo the check boxes and whittle those down, while also looking at, okay, what is the necessary but not sufficient kind of cornucopia of things that we kind of get to. So we're building out a data lake, and we have put more and more data systems in through this data lake to try to help capture that internally. I think it does call the question about, are we moving towards a person-centered case record or something of that nature, and what does that look like? What are the appropriate safeguards and understanding that help us do that better?
And we have a fabulous question that came in that I think wraps this all up for me, and is a personal passion of mine. And that is, we've talked a lot about Medicaid here. We all know the fabulous things Medicaid is doing that is sort of outside the over-medicalization box. What lessons can be applied to the broader health population and the healthcare system? How do you take these interventions, which have been proven, pretty successful within Medicaid, and how do you scale that to the entire health system? And so, it's a pretty easy question. I'm just kidding. This is I think, the $1 million, $1 trillion question. And with that, I'm going to start with Cody, and then we'll get your thoughts on this. How do we proselytize to the rest of the healthcare system?
Well, I think that we have to look at payers. I think in particular, and aside of just Medicaid, but private payers, I think we saw a lot of very quick, nimble work at the payer level in the midst of COVID, right? Opening up access, mental health services, creating, creative ways that providers could do hospital at home, an array of other things to think outside the box of what has been historically kind of medicalized and paid for. And I think that as opposed to going back, and this is what I hear from the payers that I work with, instead of going back to where we were, how do we continue that trajectory to move forward? And I think that's going to be a big question towards, this sense of, okay, well, how do we also, when people are struggling with food security and other things, more than just a gift card incentive payment to try to get the flu shot, what do some of those sorts of things look like that can prevent folks from sliding? Inevitably we have tied employment to health insurance in this country. And so, getting payers to own a piece of that puzzle, I think is going to be critical to try to prevent folks from them sliding down what I call the long tunnel towards the posturepedic mattress at the end. And I think that that's where we have to kind of do a little bit more upstream work. And I think right now we're ripe for work on mental health in particular, but then also I think food security and some other pieces, and figuring out that right clinch point at the payer piece is important.
Fantastic. Camille?
Oh, I don't even know how to do that because nobody pays for the services that Medicaid. I mean, the reason we focus on Medicaid is because Medicaid is the only payer for these non-medical services that people need in their home. We would love to have other payers join in the process. I mean, there are a number of, this law leads to long-term care financing proposals, and there's a ton out there that talk about ways to build a retirement-based, almost like a 401k benefit that people would buy into. I will tell you, the focus on social determinants of health has actually really been a laser focus on the inadequate funding of the community-based organization network that have provided those services. And if nothing else, recognizing that multiple payers, for example, should be providing compensation to those. So it's not enough to just identify the referral pattern through NC, right, 360 or Unite Us or AmpBirth or any of those platforms, but to send those individuals and refer them to an overburdened, underfunded social services system is counterproductive. And so also trying to move the conversation away to making payers, whoever they are, not just Medicaid, really invest in those systems to be able to provide transportation, housing supports, meals, peer supports for individuals that have mental health and substance use issues, where there is no funding if the payers don't pay for it, really. So I have no answer, but I would love for people to pay attention to that.
Other payers, come join.
Come join us. Come join us, because one day you will need it. I promise.
And Shavana, you get the last word.
I think, as everyone said, it's hard to tackle, right? But there are opportunities, and we see glimpses of it in a lot of different areas that have been successful. I do think it is a matter of really understanding the lived experience and trying to align the programs and the regulations to the best that we can in a way that's going to be helpful to the people who need the programs. One of the things that we often see is a change in a policy or the creation of a program that doesn't take the consideration of the people who are actually going to be using the service. And we wonder why people don't tap into those services or those resources after we put millions of dollars there, right? We've seen this. I've seen this since, we've been in Louisiana, and I saw it in Washington, where, we create these programs that we consider, to be very helpful, right? We'll create a program that will help you to match funding if you save funding, or to connect you to employment and training programs, but we make it so hard for that connection to happen. So how can we do it in a way that's seamless to a client from their experience, and make it not harder for us, because it's going to be hard either way, regardless of how we do it. It's a matter of really understanding what is the easiest way we can do it, where people will actually use the tools and the systems, and then what systematic changes do we need to make in order for that to happen, right? If we're really talking about bringing services to people where they are rather than the services to the people, what does that look like? And we can only go to them to find out what that really looks like.
Thank you so much for this thought-provoking discussion. It's been wonderful. And I know that you've had not only an impact on how people are thinking, but also actions and outcomes outside of your programs in your states by sharing your wisdom with everyone today. I will turn it back over to Maya in a minute, but because I'm very bad at following the rules like Camille, I love this one last question. So I'm going to throw it out there as a thought question for everyone. And that is, how do we wrap services around the person, the family, and the community rather than the individuals having the services sort of like being wrapped around the services? So anyway, how do we really create that wrapping in that person-centered way, which honors their lived experience and their preferences and goals? And with that, I will now turn it back to you, Mai. Thank you for indulging me with the last question. And thank you so much to the fabulous panelists.
Thank you, Cheryl. Thank you, Camille and Cody and Shavana. It was, again, a really invigorating conversation. I want to begin our wrap up by offering my observations of just a few key themes that have come out of today's conversation. We began with John Blum talking about CMS's new orientation coming out of the pandemic experience and what that means for its partnership with states, but also its approach to thinking about equity and whole person, whole community health. And we heard him talk about the need to really value something other than just cost savings, that there's some things that we may need to make net new investments in, that savings are not the only goal, and that there are other strategies we need to deploy besides payment reform, although understanding payments and how money flows is really important, as we heard in the rest of the afternoon. Also, this really paradigmatic shift of going from believing that Medicare is the 800-pound gorilla in the marketplace to now it being Medicaid, being maybe 850 pounds. And that mindset of then CMS being at the service of states and helping them to solve local problems becomes a much more central focus for the agency is really important as well. And there was also, I heard, a theme about engaging communities more upfront in a co-design effort to make sure that their priorities are reflected in programs, even if that means a longer development path, and perhaps might make some of us itchy and impatient. But then in the other two panels, I really did hear a lot of consistent themes. One, that we have to value people and the people that we're trying to serve. Beginning with that is what allows us to uplift the investments and make sense of the financing streams to support those investments for them, as well as in how we spend the money. And so, valuing people goes hand in hand with shifting power and letting the beneficiaries of whatever financing stream or program we're talking about own as much of what happens to those dollars as possible, whether that's through co-design efforts, whether that's through employing some of those same vulnerable people in order to serve their own communities better, and or self-directed dollars in the literal sense of that term in Medicaid, as well as in a more figurative sense, self-directing the investments. I heard that we want to think about, when we think about whole person, whole community health, that there are many downstream implications, such as in the criminal justice system or in education, where there are natural allies that we have not fully leveraged yet, and that's another opportunity. I heard that technology and infrastructure are absolutely critical, but they don't do the direct service provision. They merely facilitate it. And so even as we invest in those truly essential ingredients, we need to think about bolstering the human capital and defining it with more rigor, with more standardization, so that we can value it, so that we can build the pipeline, and so that we can do all that with authenticity and make sure that the people represented in the workforce come with that community street cred, that they can actually be effective as agents of change. And And I also heard that a little more prescriptiveness from central government couldn't hurt, that, that states appreciate the flexibility on some points, but it really would help to have a centralized definition of community health workers, for example, or a centralized signal that social investments in social structure really should be mandated within capitation approaches. And then lastly, two really core themes that ring true and resonate for me is one, that long-term services and supports, home and community-based services, should simply become an essential benefit, and that therefore all payers would have some accountability for them. And secondly, that until we get to that space, and even maybe after, let's just give ourselves all permission to play around in the gray of policy space and make the most of the current crisis. We have learned that not only frontline personnel and program directors, but also governments have incredible capacity to be creative, to be flexible, and to pivot very rapidly during COVID. We shouldn't let go of those skills. Maybe we can take the adrenaline level down just a little bit so that we're not feeling like we're in crisis mode. But if we acted with the permission that we gave ourselves in crisis mode, we might do much better in terms of coming up with sustainable and creative solutions. So those were some of the things that I heard, and I'm so grateful because this conversation has just crystallized so much of what was core to the spring workshop, and that will be in our special publication. But also just to put in a plug that if you want to have more conversation about how building a system for vulnerable populations that can deliver integrated care will actually serve everyone better, I hope that many of you will be able to join another National Academy of Science, Engineering, and Medicine workshop in December on building such a system for people with IDD. That's on December 8th, 10th, and 14th. And we really hope to connect these conversations because they are one and the same. With that, let me turn it over to Michael to, and any of the other moderators and speakers, if you have more to add to that very, very rapid summary, and take us home.
Thank you very much, Mai, and everyone for really an extraordinary conversation, one which has identified not just problems, but especially moved into the solutions dimension, which is what we're all about. We heard Cheryl recently that we want to avoid getting back to a siloed world, and that's clearly what we're about. Not that we're out of the siloed world, but we've at least got a societal sense of opportunity in an integrative approach to the challenges. And that's why, in particular, we've been focusing throughout this whole series on whole persons and whole populations. And that's clearly not a natural focus for a system that is fundamentally paid for piecework. So our work is set out for us. You know, turning an aircraft carrier is tough enough, but trying to turn it is extremely tough when it's under full steam, fueled by 18% of the economy. Still, we are in a different moment, if you will. What's the term that Cody used? Crisatunity. And we need to take advantage of it. There's awareness that we haven't had before. There are resources that we haven't had before. There's technology that has been increasing inexorably and now is beginning to move into onto the front line as a resource. And we have a CMS and administration which is interested in using the levers at its disposal and the signals at its disposal to try to change the mindsets and the practical realities of the way our health system is focused. And the discussion that we've heard today gives me personally optimism We heard a great deal of creativity, a discussion of the art of the possible, personal testimony about those who are making things possible. And I want to make sure that we emphasize the importance of our continuing not only the conversation, but our hearing from you as we do move forward with the conversation about ways in which the efforts can be more effective, how we can build a foundation, build on this, the foundation that's been set in the last few months of a new world, and ensure that the vision that we all have for health financing that rewards better health, equity, and well-being is one that we achieve. I want to, before we wrap up and close the meeting, to obviously thank Mai for her extraordinary work as a chair and moderator, and much more than that between the times as the chair of the steering committee. And in that respect, I also want to give special thanks to the steering committee members, of course, to the foundation supporters, to Josh and Cheryl and all the panel participants for your wonderful orchestration of an extremely talented group of panelist participants. And thanks to all of you who've attended today. And we're all part of an expanding network pulling in the direction for what's possible in terms of improving the effectiveness, efficiency, and equity of our health and healthcare system. I want to, of course, especially give thanks as we wrap up to the National Academy staff that helped to produce this meeting, including Jennifer Lee, visiting scholar, Jennifer Flaubert, program officer, Mike Cocciola, research associate, Tochi Ogumaduga, and Allison Lester, senior program assistant. So thanks again to all of you. Thanks to our staff. Please keep in touch. Meanwhile, be well, stay safe, and have a great Thanksgiving holiday. Take care.